finishing hematology, and we'll probably do half of GI, and then next week we'll do GI and endocrine and death and dying, and then we'll all be done with all the lectures. So when we left last week, I was talking about the anemias, and we were talking about the anemias of abnormal hemoglobins, and we talked about sickle cell, and now we're going to talk about basically the thalassemias. And interestingly enough, thalassemias worldwide is the most common genetic disorder. Okay, you know, there's two types of thalassemias: alpha and beta thalassemia. Okay, and beta thalassemia has more than 200 distinct mutations. Most of them are minor. Okay, 3% of the world's population carries genetic abnormalities for beta, and 5 to 10% of all Southeast Asians carry the gene for alpha thalassemia. So the gene is, widespread. Now, of the beta thalassemias, the biggest problem, okay, is thalassemia major or Cooley's anemia. Okay, this usually shows up somewhere in the second 6 months of life, and this is the severest of all the thalassemias. It's a progressive hemolytic anemia. It has profound weakness and cardiac decompensation without transfusions. And of course, they need multiple transfusions. So then they wind up with hemosiderosis. And the classic presentation of the kid with thalassemia, okay, is hepatosplenomegaly and cachexia. Okay. Thalassemia faces. Did they tell you what thalassemia faces were? The malar hypertrophy, the greenish discoloration. I'll show you what it looks like. Did he show you pictures of it? Of the faces of thalassemia?
I think so. Yeah.
Okay. And they get pathologic fractures. We rarely see that here in this country or Western countries because they have been treated repeatedly with transfusions. These kids usually need chronic transfusions by the age of 2. Okay, and then they develop hemosiderosis. So if you're giving recurrent transfusions, you then have to start them on chelation therapy to get rid of all that extra iron that they get as a result of the transfusion. In the past, there was a cure for beta thalassemia, and that was bone marrow transplantation. Okay, and 1,000 cases were successfully cured, and it had to be done basically before the age of 15. Now there's CRISPR treatments, okay, for beta thalassemia, okay, in children 12 and older. And they use CRISPR modified red cells, and they send them into the patient. And this is going to be remarkable. I mean, you're going to see more and more patients cured by CRISPR manipulation for treatment. Basically, they take bone marrow stem cells, genetically manipulate them, infuse them back. They go back to the bone marrow and they produce normal hemoglobins. So this is what you're going to see in the future, and it's eventually going to get to younger and younger kids. Other beta thalassemias, there's 6 different groups based on globin phenotypes, okay, which is different from alpha thalassemia. Alpha thalassemia is globin deletions. We'll get that through a minute. So thalassemia trait is very common and is frequently misdiagnosed, like we said, as iron deficiency anemia. Except they have a narrow RDW instead of a wide RDW. So if you have a patient who looks like they have iron deficiency anemia and their red cell distribution list is narrow, they probably have thalassemia trait. Thalassemia minor and minor, okay, is less severe than the next one we're going to talk about, but more severe than the trait. They may require transfusions as they get to be adolescents or adults, okay? and it's a heterozygous transmission. And then the fourth one is thalassemia intermedia, and they have a severe microcytic anemia. They sit around 7. And the question is, do you really have to transfuse these patients? Or if they're compensated and they do well, okay, but they will develop the medullary hyperplasia that we see in thalassemia major. And if you're transfusing, then we're talking about hemosiderosis, okay, and splenomegaly may occur. So those are the beta thalassemias, and then the alpha thalassemias, okay, most commonly in Southeast Asia. So that's the one you're going to basically see it in. And there's 4 distinct um, manifestations, all based on globin deletions rather than phenotypes. And the first one is the silent trait, and they have deletions of one alpha globin gene, okay, and basically they're unidentifiable immunologically, okay. Um, and basically you may see this in a lot of African Americans. Um, Alpha thalassemia trait, you have deletions of 2 alpha globin genes, okay? And these patients have significantly microcytic hyperchromic anemia. They also look like iron deficiency. Their hemoglobin electrophoresis is normal, and the only way you can really identify them is basically with DNA testing. Then we come down to the third variety, hemoglobin H disease. Now you have deletions of 3 of the alpha globin genes. Okay, they have a marked microcytosis and anemia, and these can be identified by hemoglobin electrophoresis. They have mild splenomegaly, and basically, if they have hemolysis, they are going to have scleral icterus and gallstones. But these patients usually do not need transfusions. And hydrops fetalis is the most severe form. They have deletions of all 4 alpha globin genes, okay? And if they survive, they're transfusion dependent. There have been 2 or 3 successful bone marrow transplants for these kids, but these are extremely rare. You're not going to see. And then the other etiologies, these were all intrinsic problems for anemia. The extrinsic problems with anemias are hemolytic disease of the newborn, and we talked about those, Rh incompatibility and ABO incompatibility. And then you have the autoimmune hemolytic anemias. And hematology makes a big difference between warm and cold hemolytic anemias. I don't. And the reason I don't make a difference between the warm and cold hemolytic anemias is if you look at the etiology for the both, okay, number 1 on the list is idiopathic. So the most common etiology of the acquired autoimmune hemolytic anemias is idiopathic. And then the secondary causes, okay, lymphoproliferative diseases are the second most common etiology. So, it's the same whether they're warm and cold etiologies, okay. Overall, secondary causes can be caused by, besides lymphoproliferative diseases, connective tissue diseases like lupus and JRA, infections, mycoplasma pneumonia, and even virus can do it, okay? Non-lymphoid neoplasms. These can all create it, and they are not very common in children. The most common etiologies in children are the drug-induced hemolytic anemia. Okay, the drug-induced hemolytic anemias are responsible for 20% of all the hemolytic anemias in the pediatric age group, and this is the ones that you're probably going to see. Okay, and the most common drugs that are responsible are penicillins and cephalosporins. Yeah, quinine and quinidine can do it, but we don't give kids quinine or quinidine very often. So if you're going to see an autoimmune hemolytic anemia, it's probably going to be due to an antibiotic. Okay. Now there's 2 varieties: the acute transient, which tends to occur in younger children, 2 to 12 years of age. Okay. And 70 to 80% of all children with acute acquired hemolytic anemia have this one. Okay. It can last for 3 to 6 months. It may frequently be preceded by infections that we talked about, things like mycoplasma or strep pneumoniae or EB virus, okay, can trigger it. And there are two presentations. It may be acute onset of frustration, pallor, jaundice, fever, and hemoglobinuria, or more gradual with just fever, pallor, okay? So a patient may come in as lethargic, pale, you examine them, they have splenomegaly, you have the diagnosis, you put them on steroids and they get better, and the mortality is very low, with almost always full recovery. That's the most common. Older kids, like adolescents, okay, they have the chronic and prolonged variety, okay? And the hemolysis may continue for months to years. The response to steroids is inconsistent. And these are the kids that the hemolytic anemias are probably triggered, okay, by lymphoproliferative disorders. Okay, the underlying disease is what's making it last so long. So that's basically the other cause of anemias. And then blood loss. And if you have acute blood loss, your anemia is going to be a normocytic anemia. If it's a chronic, prolonged loss of blood, it's going to be a microcytic hypertrophy. So that's the anemias. Okay? So before we go to anything else, what's the diagnosis on this slide? What? Oh, well, let's go to the point. All right. What's a normal red cell? This is a normal red cell. This is a normal red cell. These is normal red cells. What's going on here? And compare the size of this cell to this cell. What? So they're smaller and paler. So what's the diagnosis? It's microcytic hyperchromic. You don't want to be. There it is. Microcytic hyperchromic anemia. The cells are smaller and they're paler. Okay, and then we have this, another one again. These are small, they're a lot paler and smaller. Okay, this is probably the only normal red cell on the slide. So this is a microcytic hyperchromic anemia. Okay, all right, next slide. What's wrong on this slide? Okay, this is a normal red cell. This is a normal red cell. Normal red cell. What about this one? This one compared to this one? What? Megaloblastic, microcytic. Okay, so this is what megaloblastic anemia looks like. The red cells are bigger. They still have the central pallor that we see in normal red cells, but again, these red cells are larger. So this is megaloblastic anemia, and on high power, you can really see the difference between this one and this one. Okay, this red cell is humongous. And what's the most common cause of megaloblastic anemia in pediatrics? Folic acid. Thank you. Okay. What's going on here? Anybody? It's called basophilic stippling or Howell Jolly bodies. Okay, did they talk about that in pathology? That's what they look like. Okay. All right, next slide. What's the diagnosis here? This is a normal red cell. This is a normal red cell. What's missing in all these red cells? Central pallor. So if the central pallor is missing, what does that mean? Okay. Remember, the normal red cell looks like biconcave ellipsoid disc. They look like Bialys, okay? They're narrower in the middle. That's why there's more pallor, okay? So when the pallor disappears in the middle, what's happening to the red cell? They're getting rounder. So what is this? This is spherocytosis, okay? The spherocytosis, the central pallor is missing, which means the cells are rounder, more fragile, and what have you. Okay, next. Anybody have a problem with this one? Okay, nobody has a problem with these? Okay, this is called sick as hell anemia, as my patients used to call it. Okay, and what kind of cells are these? They're called target cells. Okay, target cells, the central clearing has a bullseye in the middle of it. That's what target cells look like. So basically, that's sickle. This is another sickle cell anemia. Okay. Okay. So now what do we have here? Well, we have normal red cells. We have target cells, and we have this sort of thing sitting over here, which doesn't quite look normal. Okay. And this is when a patient has sickle thal. Okay. It's a combination of thalassemia and sickle cell. So they have sickle cell here, and they have target cells. So this is the mutation of this. What's wrong with this kid? What? This is thalassemia. This is the kid with the malar hypertrophy, and he's sort of got this greenish tint to his skin right here. And if you want to look at the smear, this is what the smear looks like. It's a mess. Okay, this is not a white cell. This is a red cell. This is a red cell. This is a red cell. Okay, so this patient has Cooley's anemia. He has nucleated red cells. Okay, basophilic sniffling, marked hyperchromasia. Okay, you don't want to see a slide like this. He's a mess. All right, and the last thing for $64,000, what's wrong with this patient? Right? Anybody? It's staring you right in the face. But you don't know what to look at. You're looking at this thing right here. Does that belong in a red cell? Obviously not. What do you know that invades the red cell? What? No. That's the malaria. Yes, that's what malaria looks like. Okay, on a CBC, you see the malaria plasmodium inside the red cell. That's what malaria looks like. Okay.
Why is it only one?
What?
Why is it only one?
Because we were lucky to get a slide with one of them.
So
Okay.
invade all the.
They don't invade all the cells. Okay, they invade the cell, they reproduce, and then they, make more. Is basically what happens. All right, I'm lucky to have one in the cell. Okay, so but that's what malaria looks like. Okay, so those are the anemias. Now we're going to talk about bleeding disorders. Okay, and when you talk about bleeding disorders, basically the beginning of your workup involves, like everything else, history, 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 history. You really want to know whether it's congenital or acquired. You want to know whether the problem is a primary platelet plug formation or secondary fibrin clot formation. So the questions you want to ask is, where are they bleeding from? How severe was the bleeding? How old was the kid when the bleeding started? Because the younger they are, the greater the risk of them being congenital in origin. Okay. How was the bleeding stopped? Was it spontaneous or induced? Is there a family history of bleeding would help? Okay. Any medications and past experience with trauma, surgery, dental work. Okay. And in women, you want to know their menstrual history. So that's basically the history you take. And then you do the exam. Okay. And is this bleeding petechial? Is this bleeding ecchymosis or hematomas? Are they bleeding into the joints with hemarthrosis? Or is it mucous membrane bleeding, meaning epistaxis, hematuria, heavier periods, or GI bleeding? Because this will give you an idea of where the initial problem is. So if it's a primary hemostatic defect, okay, platelet blood vessel interaction, that usually presents with mucous membrane bleeding. If you're talking about secondary hemostatic defects, the coagulation system, these patients do deep bleeding into joints and muscles. So when taking a history, you'll know basically where it is. Now, I will not ask you anything about the evaluation, the workup, the bleeding factors. I'm sure hematology tested you on those and made you crazy with them. Okay, it's all there in the notes. I will not ask you about it, but basically, if I talk about the defect, you'll know what I'm talking about. Hopefully. So the first thing on the list is epistaxis. What's epistaxis? It's a nosebleed. Okay, so it's a symptom. It's not a disease. Okay, and basically, it's extremely common in children between the ages of 4 and 10. Okay, about 15% of all kids present with bloody noses. So then we talk about the age of the patient. Newborns should not have bloody nose. Okay, they just shouldn't. Okay, blood discrasions can cause epistaxis in the newborn. The most common cause of epistaxis in the newborn is local trauma. So if a mother calls me up and says her new baby has a bloody nose, okay, my first question is, what the hell are you shoving up her nostrils? Okay, because in the bad old days, they used to make both syringes for sucking out the nose. It used to be as thick as my finger, so it never went deeper than and didn't make parents happy. So then they would take the ear syringe with the long, skinny one to shove up the nose to get the mucus out, and then the kids would have bloody noses. And now we have the snot sucker and all other over-the-counter stuff that parents can buy to suck the snot out of their kids' noses. And when they start shoving catheters up the nose, the kid is going to have bleeding. So these patients usually do not need a hematologic workup for their nosebleeds if you know the mother's shoving something up their nose. Infants and children, this is when we have the common nosebleeds. Okay, local trauma, number one cause. Number two is inflammation, particularly in the winter months when the houses are too hot, the nares get dried out, and they bleed from being just dried out due to the temperature. And then allergies can do it. You know what the allergic salute is, right? Okay, this is the allergic salute. And so this is doing local trauma also to the mucous membranes of the nosebleed. The only one that you really have to worry about is if adolescents are having chronic nosebleeds. Okay? Again, the etiology is local trauma and inflammation, most commonly in a joint mucosa, but there's an exception. Because when adolescents get older, they should keep their fingers out of their nose and they shouldn't have nosebleeds. There's something called an angiofibroma. And an angiofibroma is a tumor, okay, that can erode through the upper nares into the orbit and then into the brain. And if an adolescent is really having chronic nosebleeds, you want ENT to see them to do a direct exam up the nares to look for the tumor and maybe a CT scan or an MRI to rule out an angiofibroma. They're not common, okay? Many years ago, I consulted on a case of an angiofibroma that eroded through the orbit and up into the brain, and the kid never had a nosebleed. So then the question is, how can you make the diagnosis? Okay, so this really probably wasn't malpractice because the presenting sign was visual changes. Well, when he had visual changes, it has already eroded up into the orbit. I mean, if he had chronic bloody noses, yes, then it would have been malpractice in an adolescent if he didn't do anything about it. So, number one, how do you stop a bloody nose? I'm open for suggestions. How do you stop a bloody nose? What do you tell the parent to do? Here? Absolutely not. There are no blood vessels here. This is all bone. Okay? Where are they bleeding from most commonly? They're bleeding from the septum and maybe an bleeding from an artery that runs in the inferior aspect of the nares. So how do you stop bleeding? Any bleeding. Laceration of the leg. How are you going to stop bleeding? Direct pressure. So you don't put direct pressure up here because you ain't getting to where they're bleeding from. You grab the nose right here and you hold on. How long?
Till it stops.
How? Till it stops, right? Did it stop yet? Did it stop yet? Did it stop yet? What's the normal bleeding time? 8 to 12 minutes is the normal bleeding time, right? So you tell the patients, yeah, compress the nostrils for 20 minutes. If you're lucky, they'll do it for 10. If you're 10, maybe that you tell them 10, then it's going to be 5. So you grab the nose and you hold it, okay? Ice packs on the forehead or the back of the neck is not the way to stop a bloody nose, okay? Head forward or head back doesn't mean a thing. You stop bleeding by direct pressure, squeezing the nose, okay? So now you stop bleeding. There's a clot in an areas, okay? What's the normal progression of any clot?
Scabs.
What? Yeah, any clot. You scratch yourself. You got a clot on your arm. What happens to the clot? You scratch the mosquito bite, you bled, you had a clot on your arm. What happens to that scab? Before it falls off, what does it do?
Hardens.
It hardens, dries out, and what else does it do? You know what?
Itches.
It itches. That's why the kids pick them continuously. Well, guess what? If they have a clot in their nose, what do you think the kid's going to do as the clot heals? He's going to shove his finger up his nose and he's going to pick it off and he's going to be back in the office with another nosebleed. So how do we stop the itching? And I don't care what you use. You can use Aquaphor, you can use Neosporin, you can use Vaseline. Every night before they go to bed, you put Vaseline up in the nares on the septum because that's where the bleeding came from, and you do that for a week. And that will stop the itching. That will stop the kid shoving his finger up his nose, and they will not have chronic bleeding. So that's how you treat nosebleeds, okay? Because you're going to see a lot of them, and if you don't tell them to treat the scab after the bleeding stops, I guarantee they will be back, okay? I've never had to tamponade a nose. In medical school, they taught us how to do posterior packing of the nose. You pass the nasal gas tube through the nose, came out the mouth. The mouth, you tied a nasal pack to it. You pulled it up and out, up through the posterior pharynx and up through the nose, and that packed the nose to stop the bleeding. Kids never needed that, okay? And I haven't cauterized the nose for nasal bleeding in years. I mean, I'll let ENT do it. You know why? Cauterization hurts. And I'm not going to be the bad guy. Let the ENT be the bad guy and burn the kid's nose with cautery. I have enough problems with shots. So that's basically how we do epistaxis. And then we do the coagulation disorders, and we start with phase 1 coagulation disorders, the hemophilias. That's factors 8, 9, 12, and von Willebrand's. 8, 9, 11, or 12. That's one von Willebrand's and von Willebrand's disease. Okay. Number 1, factor 8 deficiency, classic hemophilia, hemophilia A. Of all the hemophilias, this is the most common. 85% of all hemophilias are due to factor 8 deficiency. Okay. It's inherited as an X-linked recessive, which means we only see males. Okay. Females who have one of the recessive genes may have a mild bleeding tendency, but they don't have problems like the hemophiliacs do. Okay. So then do you worry about bleeding with circumcision? Generally not. Okay. Only 30% of hemophiliacs will present with bleeding at circumcision. The hallmark of hemophilia A is hemarthrosis, bleeding into joints. And it depends how old the kids are. If the kids are older, okay, basically they bleed into their knee and elbow. Toddlers tend to bleed into their ankles because they fall early. And when they fall early on their ankles, they're going to bleed early. And 90% of the patients with true factor VIII deficiency will have symptoms about a year of age. That's when they will have bleeding symptoms. My entire medical experience with hemophilias is with one family when I was a resident, 5 boys who loved to play tackle football. And one of them was in the hospital all the time with bleeding into their knees, hemarthrosis, and no matter how much we yelled at them, they continue to play football, tackle football. And if you continue to bleed into your joints, you're going to develop symptoms of pathology of muscle contracture, joint wasting, fibrosis, joint contractures. This is what's going to happen. They didn't listen. Okay, and the severity depends upon how much factor VIII is available. Okay, if you have 60 to 30% factor VIII, okay, you have a mild disease, so there's generally no spontaneous bleeding, only with trauma, like playing tackle football. Okay, 1 to 5% is moderate, less than 1% is severe disease. Okay, and basically the treatment is factor VIII replacement, which is available. Keep the factor VIII levels up. Okay, there are new drugs out there to prevent or reduce bleeding episodes in adults and pediatric patients over the age of 12. Okay, it's out there, and again, it's probably easier to use than factor transfusions of factor VIII. So again, we are progressing to medical treatment rather than hematologic treatments for the treatment of these hemophilia. Now, factor IX deficiency or hemophilia B, it's called Christmas disease. Okay, only 10%, 10 to 15% of hemophilias have factor IX deficiency. And the problem is it's also inherited as X-linked recessive. Therefore, it presents exactly like factor VIII deficiency. Just like in factor VIII deficiency, females can have a mild bleeding tendency, but it's not significant. Okay, and clinically, it's indistinguishable between from factor VIII deficiency in symptoms. Okay, and basically, the treatment is similar to factor VIII with infusion of fresh frozen plasma, and that's basically hemophilia B. Then we have factor XI, Christmas disease, which is even rarer. Okay, it's the least common of all, but it's the one hemophilia that's transmitted as an autosomal dominant. Okay, so it's associated with bleeding in both males and females. Okay, and unfortunately, if you do factor XI level, it doesn't correlate very well with the severity of the disease in these patients. Factor XI is not available. Okay, so the only way you can treat these patients is with fresh frozen plasma. And chronic joint involvement is rarely a problem in these patients. Okay, and really the only times they get concerned about factor XI deficiency is at the time of surgery. Then we have von Willebrand's, okay, which is a vascular hemophilia. And there are 8 various subtypes, and I don't care about the subtypes. I don't know if hematology talked about the various subtypes of von Willebrand's disease. This is one of the most common hereditary bleeding disorders. Of all the bleeding disorders, you will probably see a von Willebrand's. It's transmitted as an autosomal gene. The gene is on chromosome 12. Okay, and these patients have mucocutaneous bleeding. Okay, so they have nosebleeds, they have heavy periods, they bruise excessively, and they have postoperative hemorrhage. Now, the treatment, when I first read this, I had no idea how it works. The treatment for von Willebrand's disease is DDAVP. What is DDAVP? We talked about DDAVP, but you didn't use it in your research. Okay? The DDAVP, okay, basically is, come on, I went out of my head. ADH, antidiuretic hormone. Okay? That's what DDAVP is. So what the heck does antidiuretic hormone have to do with a bleeding disorder? Okay? DDAVP, antidiuretic hormone, okay? We have it in pill form, we have it in nose spray. So if you want to treat von Willebrand's, it's great. But how the heck does it work? Well, apparently, DDAVP increases the release, okay, of von Willebrand's factors from the vascular endothelium. So by giving them DDAVP, you increase the release of von Willebrand's factor from the endothelium. The antidiuretic, the von Willebrand factor goes up, and it reduces the risk of bleeding. How somebody figured this out, I have absolutely no idea. Okay, but that's how it works, and that's how it's basically treated. So those are phase one disorders. Okay, and of all of them, the only ones you will definitely see von Willebrand's, and you may see hemophilia A, unless you're working for a hematologist, you're not going to see the others. Okay, phase two disorders. Okay, this is the extrinsic symptom factors 2, 5, 7, and 10. The factors that form the prothrombin complex. These are extremely rare. I have never seen them. They're inherited as autosomal deficiencies, and the only way you can treat them is replacement therapy with fresh frozen plasma. Okay? Congenital afibrinogenemia is a rare autosomal recessive disorder where there's no fibrinogen. So in the newborn period, they bleed from their GI tract when they develop hematomas. Okay, they don't bleed as frequently as hemophiliacs. Okay, and rarely have joint bleeding, and their fibrinogen levels are unmeasurable. Okay, so basically they're going to get fresh frozen plasma. Congenital dysfibrinogenemia, the fibrinogen is produced, but it functions abnormally. Okay, and again, here they have a prolonged thrombin time, even though their fibrinogen levels are normal, and it may be associated with thrombotic and bleeding states. Again, you're not going to see this one. And this one, you should put in the back of your head for one reason. Factor 13 deficiency. Okay? The onset is mostly in infancy. And the presentation of infancy is the umbilical cord doesn't fall off right away unless it's there 4 weeks after birth and it hasn't separated. That's the first sign of factor 13 deficiency. And these kids are very peculiar because basically what happens is they injure themselves today and they get the hematoma tomorrow. So the mother he woke up with a hematoma. I don't know where the heck it came from. Did he fall yesterday? Yes, that's where it came from. Okay? And all the usual screening tests are normal. So this is basically a clinical diagnosis to figure out what's going on. And then the last of the bleeding disorder, of the coagulation disorders, is disseminated intravascular coagulopathy, DIC. And you've heard all about DIC, I'm sure, okay? It's a group of conditions that results in the consumption of clotting factors, platelets, and anticoagulant proteins. And lots of things can do it. Shock, acidosis, hypoxia, tissue necrosis. This was first reported in the late 60s, early 70s. I remember when it was first reported, okay? And in that era, we had lots of babies who presented with diarrhea, dehydration, and acidosis, or kids who had cardiorespiratory arrest and went into shock, okay, hypoxic episodes. So we saw these kids. And the recommendations were give them heparin. And the question was, give somebody heparin who's bleeding? That makes really no sense whatsoever, but that's what the report said. Now, currently, the theory for the treatment of DIC is fix whatever triggered it. If they're hypoxic, fix the hypoxia. If they're acidosis, fix the acidosis. If you get them out of shock, they'll be better. The body will respond. If it continues, then you give them heparin for treatment for unresponsive cases after basically you've treated them. If they present with septic shock like meningococcemia, I've seen that too. Okay, they may develop DIC as well. Fix the trigger, and then in rare cases give them heparin. Now, what about platelet disorders? Well, we have congenital platelet disorders and we have acquired platelet disorders. You're not going to see the congenital thrombocytopenia. Okay, they're extremely rare. Again, Wiskott-Aldrich. Okay, these patients have thrombocytopenia, eczema, and recurrent infections due to immunodeficiency. It's inherited as an X-linked disorder. Okay, and if you do a splenectomy, it'll cure them, but will get rid of the destruction of the platelet. Okay, but the only way to cure these is by bone marrow transplantation. Then we have congenital amegakaryocytic thrombocytopenia. This is rare. It presents in the first few days of life. They develop petechiae purpura. They look sick as hell. They go into bone marrow failure, and they can only be cured by bone marrow transplantation. You're not going to see this one. TAR you may see, okay? But TAR stands for thrombocytopenia and absent radius. Which do you think you're going to notice first? The fact that the kid has thrombocytopenia or is missing his radius and his thumb. Okay? I think you will notice the absent radius and thumb long before you notice that he has thrombocytopenia. In addition, these kids have short stature, renal anomalies, hyperreflexia, microcephaly, ear and hearing abnormalities, okay? And the initial GI bleeding may be secondary to a formula intolerance, so they may have GI bleeding, okay? Interestingly enough, the thrombocytopenia in these kids usually gets better after the first year of life. All their other problems don't. So this is extremely rare. And then there's something called Caspar-Merritt syndrome. And Caspar-Merritt syndrome, basically, these are people with large cutaneous hemangiomas of the trunk or extremities, maybe abdominal viscera. And what happens with these patients is that hemangioma traps platelets. So because it traps platelets, okay, they may present with thrombocytopenia because the platelets are trapped within the hemangioma. Okay, and they may regress in time as the patient gets through infancy. And the treatments are surgical excision, laser photoregulation, high dose steroids, X-ray treatment. Okay, I had one patient with this. They had a hemangioma of his lower extremities. The kid looked fine. He wasn't thrombocytopenic. He had no episodes of bleeding, nothing. And they wanted to do all sorts of treatment. I said, let's wait and see. We said they get better, okay, as the kid gets older. Well, by 5 years old, the hemangioma was gone. The kid is perfectly normal. That's 15 or 16 years old now. No problem, no surgery, it got better. So these kids with Caspar-Merritt can be watched if they have no evidence of thrombocytopenia. These are all uncommon. Acquired thrombocytopenias, on the other hand, are a lot more common. These you will probably see, okay? The peak age of acquired thrombocytopenia, this is called ITP, idiopathic thrombocytopenia purpura, okay? Between children of 1 and 6. Generally 2 to 5 is when they peak. It frequently follows a viral illness by anywhere between 1 and 4 weeks of age, okay, in about 50 to 65% of the cases. We blame it on an autoimmune etiology, even though we have no idea how it's transmitted or how it happens. But these kids wake up one day with petechiae purpura all over their body, and they may have nasal or oral bleeding. But despite the evidence of petechiae or mucosal bleeding, they look fine. They don't sick at all. Okay? 80 to 90% of them get better if you do nothing. It may take 9 to 12 months, but they will get better. Okay. And here's the, you know, therapy does not alter the natural cause of the illness. It may increase the risk of platelets after treatment, but they're still going to have um, persistent thrombocytopenia for a while. So what is everybody afraid of with ITP? You got to treat this or else where are they going? Into their brain. And that's what everybody's afraid of. Oh my God, they have ITP, they may bleed into their brain. Guess what? They don't. Less than 1% of the kids with ITP have intracranial bleeding. Okay? 10 to 20% of them may go on to form the chronic variety, but most of them do not bleed into their brain. So what are the treatments out there that are available? Okay? Well, prednisone is one of them. Okay? And prednisone has been shown to induce a more rapid rise in platelets than doing nothing. Okay. Intravenous immune globulin may induce a very rapid rise in platelets within 48 hours. They ain't let you, the hospitals are not going to let you do this. Okay. Why are they not going to let you do this? Well, let's start. Prednisone, the 20-kilo kid. Okay. That's the kid that weight between the age of 2 and 5. Okay. You put a kid on steroids for 5 to 7 days. You don't have to pay for it. You get a rapid rise response rate anywhere from 50 to 77%. The platelets go up. Okay. And the cost of that currently is about $786. Well, not bad for a rapid rise of platelets. If he's symptomatic, you want to give him some steroids. But if he's not symptomatic, you really want to treat him. Okay. And remember, thrombocytopenia may also be a presentation of a malignancy. And if you put them on steroids, you may mask symptoms. So that's a potential problem also. How about intravenous immune globulin? Okay, for the same kid. Single dose. Has to be done in the hospital because it's an IV infusion. It takes a long time. The cost is $2,500 for one infusion. There is a shortage of human immune globulin. Nobody going to let you do it in the hospital. The insurance companies are not going to pay for it. And the problem with intravenous human immune globulin is there's a black box warning of thrombosis with its use. So the patient isn't dying from thrombocytopenia, and you may kill them by inducing thrombosis with your treatment. They're not going to let you do that. And the other one out there is anti-D immune globulin, a single dose, okay, is about $2,000. Nobody's going to pay for that one either. So those are the treatments out there. You don't have to, but nobody's going to let you do it. Okay, so that's one of the issues. If they're severely symptomatic and they transferred over into the chronic variety, you may want to do a splenectomy. And the splenectomy is reserved for children over the age of 4, okay, who've had chronic ITP for more than a year. Those are the kids who get a splenectomy. But ITP you'll probably see sometime in your career. It's not very common, but it happens. Drug-induced thrombocytopenia, that happens, and it's an immune-mediated destruction of the megakaryocytes, and the most common drugs that do this are the anti-seizures medications like valproic acid and phenytoin. Antibiotics can also do it, like carbamazine, sulfonamide, or sulfamethoxysterol, trimethoprim. Those are the 3 antibiotics to do it. Now, if you have somebody on chronic therapy for their seizures, you may want to monitor their CBCs and platelets because it may happen. Other presentations of thrombocytopenia, one is hemolytic uremic syndrome, We talked about that when we talked about urology. Okay, E. coli H157H7. Okay, these patients have thrombocytopenia, but they also have significant anemia, acute renal failure. Okay, and they're really sick. The fatality rate of these kids are about 30%. Thrombotic thrombocytopenia is rare. It's usually in adults, but may occasionally occur in adolescents. And here you have fever, microcytic hemolytic anemia, thrombocytopenia, okay, and abnormal renal function and CNS changes. So these patients may show up with looking like hemolytic uremic syndrome, but they also have shifting neurologic symptoms, shifting aphasia, blindness, seizures, okay, because they are producing clots throughout the body. And the treatment for this first is recognizing it immediately, and then plasmapheresis, okay, basically filtering their blood through charcoal, okay, can treat this in 80 to 90% of the cases with prompt recognition. Steroids and splenectomies for refractive cases. And the last of the thrombocytopenias are newborns. Okay? This is a primary disorder of the megakaryocyte. And most often it's the result of systemic illness, like torch, or transfer of maternal antibodies against platelets across the placenta. So this is the Rh incompatibility type of lesion, except it's with platelets instead of red blood cells. Okay, 30% of these patients develop intracranial hemorrhage. These are the kids who get IV immunoglobulin, because if these kids come out with evidence of severe thrombocytopenia, they get treated with IV immunoglobulin. All right, that's the end of idiopathic thrombocytopenia, and then we have the non-thrombotic purpura. And remember, we were talking about sources of hematuria, and I said one of the things is Henoch-Schönlein's, which was a vasculitis, and we don't know what causes it. And I said to you, once I show you the slides, you're never going to forget the diagnosis. This is the slides. This patient comes in, and they only have the rash on the extensive surface of the arms, the buttocks, and the extensive surface of the legs. The rest of their body anteriorly, they're perfectly clear. Okay? And again, there's this one. Okay? Extensive surfaces of the legs and buttocks. That's the only place you see this rash. Okay? And these kids usually come in, okay? Again, they're young, they're between 2 and 8 years of age. Okay? And this is a vasculitis of small vessels. And it involves the vessels of the skin, the joints, the GI tract, and the kidney. That, all the small vessels. So they may present with hematuria. They may present with joint pain. They definitely have a rash, and they may present with abdominal pain. And this is, you're going to have to see them. And the rash may not be present initially. Okay? It's more common in males. Okay? And the rash begins in crops that last for 3 to 10 days, but may continue for up to 3 to 4 months. Okay? And the joint pain that's involved is usually they come in complaining of knee and ankle pain. They come in. Okay? 25 to 50% may have hematuria. And like we said, abdominal pain. Okay? And basically the only treatment for this is hydration, pain relief, and steroids. I had a new patient come to me, and she said to me, my kid just got out of Kings County Hospital. He came in with abdominal pain and hematuria, and they let him go. Okay, somebody told me to come to you, so I came, and he had this weird rash. She showed me the picture. Everybody has cameras. She showed me the picture of the rash, and I said, Oh, he had Hanok lines. She said, how do you know that? I said, because the only people who present with a rash like this is Hanok lines. It's that classic. So that's non-thrombotic purple. Okay. So those are all the bleeding disorders. Now we come to the fun part when we're talking about malignancies. Okay. Now you should be aware that cancer in children is extremely rare. In 50 years of practice, maybe I've seen 20 patients with some sort of malignancy. So they're not walking through the door any day. I remember, when I first went into practice and I into practice for a year or two, and it's like, am I missing malignancies? I haven't seen one. I haven't seen a leukemic. I haven't seen a diabetic. These diseases tend to occur in groups. I don't know why, but for years, no diabetic, and then three come in within 2 months. That's the how they present. I don't know why. Same thing with malignancies. So it's not rare. Only 1% of all new malignancies diagnosed in this country are in children under the age of 19. Okay. They may be the fourth leading cause of death in children between 1 and 14 years of age, basically because from the malignancy. Okay. And malignancy in children are more commonly associated with developmental defects, chromosome congenital abnormalities, cytogenic or chromosomal abnormalities. These are the common etiologies for malignancy in children, as opposed to adults. Okay, the adults, their malignancies are more common to environmental exposure. Like lung cancer with cigarette smoking, that kind of thing. Skin cancer with sun exposure. I mean, these are, breast cancer, depending upon where you live, we know breast cancer in women is higher on Long Island than it is in the rest of in New York City. So this is because of exposure rather than what we see in children. Okay. Carcinomas almost never occur in children. 60-90% of malignancies in adults are carcinomas. Okay. So the most common tumors in children involve three systems. Number one, the hemopoietic system. Number two, the central nervous system. And then number three, connective tissues. Those are the three most systems involved with malignancies. And how do we diagnose malignancy? Are we going to do it by the symptoms? Well, this is where it starts. Okay. Fever of unknown origin. 10 days of unremitting fever. Okay? That's a warning sign. That's something bad, whether it's malignancy or something else. Fever of unknown origin is a trigger. Pain, headache, bone pain, joint pain. But the pain has to wake you at night. Okay? If the pain doesn't wake you at night, you don't worry about it. So if kids come in complaining of headaches all the time. So the first question I ask is, does the pain wake the kid at night? If it doesn't wake the kid at night, I know this kid doesn't have a brain tumor. You don't need a CAT scan. You don't need an MRI. Okay? If it's not waking the kid up at night, it's not a malignancy. Obviously, there's a palpable mass of this purpura. Alarm bells should go off. Mark pallor. If there's sudden onset of a gait disturbance or balance problem, you have to think of a posterior fossa or cerebellar lesion. There's a head tilt, okay? Change in personality is a supratentorial tumor. Except the majority of malignancies in children are infratentorial. So changes of personality, basically, you're not going to see in children, okay? And obviously, if they develop a squint or loss of the red reflex, that's another issue. So we should talk about the leukemias, okay? The leukemias are the most common malignant neoplasm in children. 40% of all malignancies in children, okay, under the age of 15 are due to leukemias, okay? But the annual incidence is 4 per 100,000. So again, they're not walking through your door every day with a malignancy. Now, two recent studies that I'm going to tell you about, okay? One from 2023. Major study confirms CT scans are linked to leukemias in children. So basically, okay, if you're working in the urgent care and every kid who comes in with a minor head trauma without loss of consciousness, if you're ordering a CT scan on them, you're going to increase their risk of leukemia down the line. Is there a question back there? No? You didn't have a question? Okay. All right. A single CT scan increases the risk of blood cancers in children by 16%. I had one kid, football player, had 5 CT scans. I screamed bloody murder at the mother. Okay? If he has a head trauma without loss of consciousness and any neurological symptoms, don't let them do a CT scan. Okay? 100 milligrays of radiation, okay, which is what they use for head CT scans, increases the risk of malignancy. And the average CT scan is 8 milligrays. So, 10 CT scans, and you're definitely getting a malignancy. So basically, the numbers of head CT scans in the United States are 5 to 9 million CT scans a year. Okay? So again, this is one issue. All right? And this came out last year in April. Okay? A risk model suggested in the 2023 study 100,000 future cancers over the lifetime of the patient. Okay? So again, all right, 62 million patients who underwent 93 million CT examinations in 2023. Okay? They say 103,000 radiation-induced cancers are possible. So again, you have to be very careful when you're thinking about CT scans. They're not as helpful as blood tests. Okay? And then, okay, I'm gonna love this one. Okay? Up to 10% of pediatric hematologic malignancies are attributed to imaging-related exposure. Okay? So these are the ones. Now, the other one that's out there, which is lots of fun, okay, is high ambient temperatures in pregnancies are associated with childhood leukemia. If you're pregnant in the first trimester, okay, and you're exposed to temperatures higher than 86 degrees Fahrenheit for more than 1 week, okay, increases the risk of leukemia in children. Well, it ain't too bad living here. I mean, even though we had temperatures of over 100 degrees this year, imagine living in Phoenix, Arizona, when the temperatures there are 116 degrees during heat waves and you're in your first trimester. The suggestion here is you don't leave your house, okay, for the first trimester, because again, it's going to increase the risk of these children developing leukemia. So again, these are the things you should be aware of, particularly of where you're living. How do these kids present? Okay, the initial presentations are non-specific and very brief. Am I missing it? 2/3 of patients with ALL will have symptoms for less than 4 weeks prior to diagnosis. And the initial symptoms are not very helpful. The initial symptoms, basically anorexia, lethargy, irritability, and low-grade fever. Guess what? You got the flu. I mean, that's basically what it sounds like, or any viral illness. Bone or joint pain, okay. Well, they have bone or joint pain that wakes them in the middle of the night. Bing, bing, bing. These are the patients you want to pay attention to. If they subsequently develop pallor, purpura, petechia, bleeding, okay, these are the ones you want to work on. Now, the first leukemic I diagnosed was a patient who presented with fever of unknown origin. That's it. He had a fever for 10 days, couldn't find the focus, okay? So after 10 days of 101, I admitted him to the hospital. We did the workup, okay? It pointed to malignancy, okay? And he had his bone marrow, which made the diagnosis. The easiest diagnosis I ever made, okay, was a mother who called me up and said to me, my kid's had 105 fever for 5 days. I can't get hold of my pediatrician, and I'm concerned about the purple spots. Well, purple spots and fever is always a bad sign. It's either meningococcemia or something else. Okay? You never want to ignore fever and purple spots in anybody. Your blood pressure should go up if you see this. So the kid came in and she was as pale as a ghost. They did a CBC. She had 3 grams of heme. So I said to mom, look, you don't know me from a hole in the wall. Okay? I understand your concern, but you have to see a hematologist. I'm making the call now. I'm getting you an appointment immediately because your child is very, very sick. And I said I never saw the child again because she wasn't my patient. And of course, I was the bearer of good news. They never come back to the bearer of bad news. So, but this was, I guarantee, this was a kid definitely who had leukemia. Okay. So, what are the prognostic factors when you're dealing with children who have leukemia? Okay. Everybody want to know what's the chances. Now, currently, the cure rate today for ALL is over 90%. We do very well in treating these kids, basically, with the LL. We really do. Okay? So, what's the prognostic factors? Well, obviously, females are better than males. That's true for almost every disease except thyroid disease. Okay? The male is the weaker sex, despite what everybody thinks. Okay? Oh no, if men had to have babies, it would be the end of civilization. Okay? So, males do poorer than females. We said the average age of kids with leukemia, okay, with ALL are generally younger kids, 2 to 6 years of age. So obviously, if you're under 2 or over, say, 8 years of age, over 6 years of age, your prognosis is worse. The white count on presentation, okay, if your white count is below 10,000 cells, there's a better prognosis. If it's over 50,000 cells, and your smear looks like this thing, your prognosis is poorer. Because there are no red cells here. This is all lymphocytes. Okay? So the prognosis is poorer, and Caucasians have a better prognosis than African Americans. So obviously, a female who's of the age of 2 to 6 years, whose white count is below 10,000, okay, who's a Caucasian, has a better prognosis than an African American male whose white count is over 50,000, okay, and is under the age of 2 or over the age of 6. But I never play the game prognosis because if the kid lives, it's 100%. If the kid dies, it's 100%. So, making numbers, I don't play that game. Now, the current treatments for ALL are very good. Why are they very good? Because in the late 60s and 70s in the United States, every kid who developed leukemia was plugged into a study. The hematologists did not have a choice of what drugs were used. They were put into a double-blind study of what concoctions that would be used. And then they found genetic markers in the leukemic cells, which determine which drugs work better. So obviously, the diagnosis of leukemia, one, you need a bone marrow for diagnosis, but number two, you need the bone marrow, okay, to look at the morphology and cell membrane markers and cytogenic, molecular, and genetic factors, because now we know with these factors which drugs are going to do the best, okay, and which treatment schedules are going to work, and that's why the success rate is as high as it is today. Okay, so it took a long-term study over the years, but now they found drugs that are specific to the specific pattern involved in each patient. And I'm not going over the drugs because I'm not a hematologist. Okay, then we have acute myelogenous leukemia. Okay, again, only 10% of all the leukemics have acute myelogenous leukemia, kids in the United States. And this has been associated with chromosomal abnormalities. And the initial presentation is exactly the same as ALL. They present exactly the same way. The physical findings are identical as well. The only difference is these patients may have subcutaneous nodules that look like blueberry muffins, but the blueberry muffin baby is, again, not selective to AML. We see it also in neuroblastoma. We see it also in TORCH. So it's not specific to AML. Okay. So again, this is basically diagnosed by bone marrow. It's a bone marrow diagnosis. Now, chronic myelogenous leukemia, the hematologists seem to love this one. Okay, because this leukemia, okay, 99% of them are caused by a specific translocation known as Philadelphia chromosome. Okay, but it's only responsible for 2 to 3% of all malignancies in children, all leukemias in children. So, why would I ask anything about, chronic myelogenous leukemia? You're never going to see it. Okay, the hematologist will. Okay. I missed that. I'll ignore it. Okay. Basically, it begins as a chronic phase, not an acute phase like we see in the other leukemics. The chronic phase lasts somewhere between 3 and 4 years. Okay. Again, the initial presentation are very nonspecific. Physical findings may be the same as ALL, except these patients develop splenomegaly, significant splenomegaly, okay, during, I guess, the blast phase. So this is chronic myelogenous leukemia. I'll tell you what, it's 9:15. Take 10 minutes. I'll give you a break, and then we'll come back and finish talking about other leukemia. I mean, the other abnormalities.
It was supposed to be like my first time.
I actually wrote on it. I just want like I want to you want to see it? Yeah. That's what I know. Saying I'm gonna have what did you I really want it. I look really fun. Anyway, that girl looks like that. It's only like 25 cents. The other I want it to feel like
Yeah, we're those
I haven't been at it.
Yeah, yeah, and one of the more than just numbers go and top. Yeah. Let's be honest. Still, I've got 5 years. Yeah. Let me see. Oh, I think you're recording.
Yeah, I'm talking about them.
Oh.
Yeah, they're good. Honestly, I.
Yeah.
Me, I had enough for time.
Pretty open because I was like, I was looking at she's gonna die, and then it's that 45-minute like drive. Okay, fine. So like traffic, rush hour. Yeah. Right. Okay, so look for the right to annoy with the large and broken like. No, now what do you call abdominal pain?
I'm like shopping.
My friend wants the bar.
Okay.
Like what your options.
He just looked back at the rate. Did I mention another? Yeah. Oh, like he said, you're
Like, not really.
eighth grader that's being and then he said, of course, family was but you know, like, and then, yeah, you know, like, I asked you,
Yeah.
well, yeah, that's that he goes on. What about the onset information? What else is there other than the same one?
But my friend wait,
That's why. Okay.
But if it goes to next semester, those I'm gonna.
Yeah, those we need to know. So much that. The first thing about the notes and things, just get from your index.
Oh, yeah.
It doesn't say.
Keep my trend. I have like 2 stars on it. Try it. Well, I got approached, I like respond, but they don't really tell us like what number it's from. Oh, it's
That's that.
what do you call it? It's hepatitis.
Probably gotta get.
According to the accent, either yes or words. She said, Steve's were probably not calculated. I'm not focusing on it.
Five.
Probably them too. I was testing on, there's not much material.
No.
It's not a generation, it's just.
For 4 $8.
Is it a D?
Okay, so it's the cutoff. So basically, if there is a family history that a woman was less than 65 and she had a cardiovascular that was less than 55 that had a cardiovascular disease, that's like the family. Oh,
Yeah, my friend.
Yeah, exactly. Like if someone younger, like a male that was 55,
Yeah.
dad or someone, you know, and now better family history. Guys, that a plastic spoon by any chance?
I think I should have.
I love you, but like that. Yeah.
He was in the doctoral yesterday.
Oh, yeah.
Diagnosis. Ben told me that, and then I typed in like what it was, and I got it right first time.
Oh, yeah, that's the one.
So,
It's really hard. My PA counsel gave me really good history.
That's That's actually.
yeah, that's the worst.
I've seen them they just.
Yeah.
Also,
Yeah. I think he does.
like after the test, I was
I got it first try because look, that's a joke. I sent you this.
I heard what you said something.
Yeah, before I was like, I don't know, I'm just gonna go with this. Should I try it?
Oh yeah.
First try. You said what it reminds me of.
Years.
I don't know. I don't know. I'm sure we can get that.
It's an F.
What was the question on?
Hey, I got it from that.
What, the first one? Yeah. So I look like.
I didn't.
Oh, I actually Googled how to spell it before I typed it.
Well, could you guys like? Who's going down for this?
What do you think they're better than me?
Yeah.
Do you think they're better?
This one, where it's like investigations.
Oh, okay. I guess I guess. It's there, but it's not the same. That was me yesterday. So.
Yeah,
That's fine. It goes like predictors of future inventions.
it is. It's like a
Future
very
repetitive.
It's like I said, I do it.
So they're all like the same.
But when he talks, he doesn't repeat himself. That's the crazy part. Like he doesn't read his slides when he should. And then after studying HDL, they should be fine.
Did you hear when you type your name?
And like, yeah, that's the only thing.
I don't know.
And then, like, exactly.
I got those.
It's much harder to get HDL to go off.
Right.
Like for hypertension, like all those numbers are not surprising. Like, you know, like, I just feel like I don't know what to get sure about like the things that they should do.
Yeah.
Not pharmacological, like some medications, they said like exercise, this amount of time for this hour.
Oh, I
night.
remember. Yeah, right.
And then it lowers the pH
Yeah,
by
yeah.
5. I don't even know. Well, antimicrobials never work how it works. Here, this one. Then, oh, you're going for now. Oh, my God.
Yeah, they use guys.
Like this.
Yeah. Like with him, like,
For like, say, 1 milligram, if you lose 1 milligram, it lowers the
At least not a lot of. They kind of reach.
Yeah, that's
But
what
it's not a lot of.
But like here, like.
the guidelines.
Okay, yeah, I have it on.
I don't know if we actually.
Like 65.
I know you said no, but then.
He said you have to know. I guess I'm going, but like you have to know that. You have to know
Like how much
like
behavioral intervention
and stuff.
Yeah, some certain.
He said it.
Yeah.
Or do you like do like like I have here that's important.
Right.
I put it like he
Oh,
said important.
Yeah.
I'm gonna go.
Below
I
start.
like,
Then they come back.
I don't know.
That's basically everything. No, like, if they're below the guidelines, or below like the threshold risk, lifestyle, then they come back.
Like 65%.
Well, it's been towards the next question. You guys should go back in terms of like, what should be the most helpful, or which should be the most.
Physical activity.
Right.
Diet is the most helpful. He said losing weight.
If you have no
Just losing weight.
We have to know that it's most helpful to.
Maybe 25 people.
Like how much?
I think that. Well, yes.
It's actually very clinical. Like from his first pharm exam, it was very clinical.
Yeah.
Like even the one that we had to know like the numbers or like the what is it called? That we had to factor the bacteria, like bacteria. You want to know? Remember like the lowest number being like the best one to give of this class. Like we had to remember which ones had to be like low and be high. That's it. That's what we had to know. It's like
Yeah.
be high, be low. It's the lowest number. That's the best one to give.
That's all.
Like, I don't guess any numbers.
Anything better than?
Clinical. Even like a whole piece of math and like which sort are you gonna get? What's the mechanism of action? Yeah, they call me they're like we need the best. We should look mechanism of action. Like social action. Feel good for he's gonna give us like adverse reaction. Can't get the no, well, I have to say no. I didn't.
But actually,
I actually taught
That could be like
everybody that
like
met.
what drug we have to get.
Like I feel like we give you one.
Oh, a patient has this. I don't know. And then someone said it's
Then I messed it up.
or no, is that true? How we want it, like, is that true? Like,
There's no dental.
but it's a lot of I guess.
No,
Take the hoodie back up.
Would it be like that black?
It was like you like saw
And then it was. Cause I feel like a lot of it you kind of know already.
Yeah, I know.
So my friends.
Yeah, so you had a lot of like nice talking about drugs. And then about it on top, and then you did like a whole, I don't know, every minute, again, and I feel like it's almost like
Anybody got any
which kind of like went on and then like so you have like already like you know that that's the eye problem when you're someone that has like but then it goes to
It's really not important. What else?
Yeah, there was something on Saturday. Yeah, it's fine.
Much better.
It was awesome. It's like that.
For the cycle, but I just.
Some, they don't like that. I like that. So, you're no, I have to ask you questions.
Yeah.
Come downstairs. Hello. All right, we talked about hemophilia malignancies. Now let's just talk about CNS tumors. CNS tumors are the second most common malignancies in childhood and adolescence. Okay. In the CNS tumors accounts the most common solid tumors in the pediatric population. Again, it's not very common. It's higher in children up to the age of 7. So most CNS tumors you're going to diagnose again in in younger children. The problem is, okay, the mortality for CNS tumors in some can approach as high as 45%, which is lower than ALL. And the problem with that is the treatment for brain tumors are a problem. Surgery is difficult. How much of the brain do you cut out? Okay. The medication doesn't cross the blood-brain barrier, and if you're using radiation, how much radiation can we give without destroying big chunks of the brain? So this is a problem. Okay, there are 2 types of tumors: infratentorial, which are mostly cerebellar tumors, and supratentorial, which is cerebral lesions. Okay, and the prognosis depends basically upon the type and the rate of growth. The infratentorial tumors are the majority of brain tumors in children, 50 to 70%, as opposed to adults who have supratentorial CNS tumors. So the symptomatology of cerebellar-like lesions are headache, vomiting, papilledema, which means increase intracranial pressure, torticollis, meaning the cerebellar tonsils have been herniated, blood vision, diplopia, nystagmus, cranial nerve palsies, and upper motor neuron deficits. This is how they present. Okay, supratentorial tumors, cerebral tumors. So then you have focal disorders, motor weakness, sensory changes, speech disorders, seizures, reflex abnormalities. Babies with a supratentorial tumor may have a hand preference. At what age do you develop hand preference? What age do you know whether you're left-handed or right-handed? Somewhere between ages of 3 and 5. Okay, infants should not have a hand preference. If they do, it's a potential problem. Okay, and basically, there is only one supratentorial tumor. We'll talk about that in the pediatric population. As far as infratentorial tumors, okay, astrocytomas are the most common brain tumor in kids. Of all the brain tumors, 40% of them are astrocytomas. They occur in the cerebellum. They are benign, and the survival rate of astrocytomas is 80 to 100% in children because they are non-malignant. Okay, malignant astrocytomas, on the other hand, okay, are result in death, and the 2 most famous people that had malignant astrocytomas, like Ted Kennedy and John McCain. That was their brain tumors, and they both died from their brain tumors. They were malignant astrocytomas. Blastomas. This is the second most common posterior facet tumor. It's an embryonal tumor of the cerebellum. Again, the mean age is 5 to 7 years of age. Again, more common males than females. And the survival rate of these malignancies is also 60 to 70%. Ependymal tumors, these are derived from the lining of the ventricular system. It accounts only for about 10% of cerebral tumors in kids, okay? And the majority of them, if you're going to get them, again, 70% are in the posterior fossa. Again, young kids, mean age of 6 years of age, a third of them before the age of 3. And the long-term survival of these is lower, about 40%. The last of the infiltratorial tumors is the choroid plexus tumor. This is extremely rare, okay? It's only about 2%, 2 to 4% of all CNS tumors, and it's the most common tumor in infancy, because this is the tumor we talked about when I was talking about hydrocephalus, where the problem is this tumor increases the rate. It's in the choroid plexus where cerebrospinal fluid is produced, so it increases the rate of CNS production, okay? So these are the babies that present with increased intracranial pressure. The babies may be microcephalic with focal neurologic deficits. But again, this is not very common. The only common supratentorial tumor we talk about, and it's 2 to 4% of all CNS tumors. So again, it's not common, okay? Craniopharyngioma is in 5 to 10% of all childhood tumors. It's the only supratentorial tumor, and it's the craniopharyngioma. What's the craniopharyngioma tumor of? It's a tumor of the pituitary. Okay, so what do you think the most common presentation of a craniopharyngioma is? It's short stature. Kids who go to the endocrinologist for short stature, the first thing the endocrinologist is going to do before he does, the growth hormone deficiency test, is they take a lateral X-ray of the skull. And what are they looking for? Where does the pituitary sit? Oh, here's anatomy again. I didn't think I have to know that anymore. Remember the sella turcica? The Turk saddle sitting with, that's what the pituitary sits in, the sella turcica. Look at the craniopharyngioma. The first thing they're going to see is erosion of the sella turcica. And so the kid who presents with a short stature, who winds up at the endocrinologist, okay, they take a lateral X-ray, okay, and then they make the diagnosis. Okay, so now you got a tumor of the pituitary gland. How do they remove it? Through the nose. They go up through the nose because that's where the pituitary sits, and they remove it. Okay, so then they remove the pituitary, radiate them, they take care of the malignancy, and now what? Now what happens? The patient fine? No, of course he's not fine. What's he missing? What?
Growth hormone.
Everything. Yeah, he's missing growth hormone, sure. He's missing TSH. He's missing adrenocorticosteroid stimulation, ACTH. He's missing antidiuretic hormone. He is missing everything the pituitary produces, and you have to replace it. With all the hormones, you have to basically replace all the hormones whatsoever. Okay? And then when he hits puberty, basically what you have to do, okay, is give him secondary sex characteristics by giving testosterone or estrogen, whichever it is. One kid in my practice. That's it. Okay? And he was a sweet, we did a great job because he was just cool by the time we got through to him. Okay? But that's craniopharyngioma. All right. Other malignancies that we're talking about, okay, lymphomas. Third most common malignancy in children, second most common etiology for solid tumors in children. And we have Hodgkin's and non-Hodgkin's are the two more common ones. Okay? Hodgkin's disease is rare in children. Okay, only 5% occur in children under the age of 5. Okay, and only 15% of teenagers between 15 and 19. The big uh, population that presents with Hodgkin's disease, okay, is the 15 to 34-year-old, the young adults. Okay, that's the typical age range for Hodgkin's. It also occurs in old farts as well. Okay, but basically, males are more common than females in Hodgkin's of young children. When you reach the more common age of Hodgkin's, the 15 to 34, 35-year old, the age range is equal in males and females. Okay, and there's a family tendency or predisposition because there's a genetic predisposition to develop Hodgkin's disease. So my late wife had Hodgkin's disease, and her brother developed Hodgkin's disease. 4 or 5 years later. Okay, it tends to run in families. How does Hodgkin's present? Okay, it presents generally with a painless, firm cervical or supraclavicular mass. Okay, which tends to be rubbery and consistently fixed to the underlying tissue, and they have systemic symptoms like fever, weight loss, and drenching night sweats. When you have somebody who has unexplained weight loss, persistent fever, and drenching night sweats, and they got a mass, they have Hodgkin's disease until proven otherwise. I mean, basically, that's how it presents. Okay, the lymphadenopathy can also be inguinal and axillary, but again, more commonly it's cervical and supraclavicular. Okay, basically, if it's diagnosed by biopsy, and then there's Ann Arbor staging, which I will not get into. I don't know if hematology got into it, but I won't get into it. The staging of Hodgkin's disease is based on a solitary lesion, which is extremely rare. By the time you have a single solitary lesion, we usually have mediastinal involvement. And then if you have mediastinal involvement, there's involvement above or below the diaphragm. Obviously, the more widespread, the worse it gets. In the bad days, the treatment for Hodgkin's disease used to be mantle radiation. They used to radiate the whole mediastinum and the area where the malignancy is. And that created a major problem in the long run. My late wife, had Hodgkin's disease in her 30s, and when she was in her 50s, late 50s, early 60s, she developed breast cancer secondary to the Hodgkin's disease, to the radiation. Her brother, when he had mantle radiation, had his first heart attack when he was 48 due to damage of the coronary arteries from the mantle radiation. They don't use mantle radiation anymore. Now they use more localized radiation to treat the Hodgkin's disease to limit the side effects. Non-Hodgkin's lymphomas, this you'll probably see in kids. Okay, it's a heterogeneous group of solid lymphoid tissue. EB virus is responsible for producing Burkitt's lymphoma. Okay, and there are 3 subtypes: lymphoblastics, which is generally intrathoracic tumors in older kids, 12 years and older. The Burkitt's and non-Burkitt's lymphomas, again, are younger kids, 4 to 6 years of age. Okay, and male and female incidence is equal. And this is a rapidly growing mass in 80% of the cases. And then there's the large B-cell lymphoma in young adults and adolescents. I have had 2 non-Hodgkin's lymphomas. Okay, the first one was in a young lady. One of the people, PA student, comes into my office, goes to examine the kid. Okay, comes out to me and said, "He's got a mass in his abdomen." She had a mass in her abdomen, which is big. Okay, that was the first Burkitt's lymphoma. Okay, she had surgery. She's an actuary. She's cured, no problem. The next kid came in with all the signs of mono. Okay, fever, lethargy, hepatosplenomegaly. Okay, thought he had mono. Sent for a blood test. EB virus was positive. Oh, you got mono. Only he didn't get better, and his spleen got bigger. So now his spleen is down into his pelvis. I thought his spleen was down into his pelvis. So I sent him a sonogram, and he had another mass. It was a Hodgkin's lymphoma. It was resected. He's in college now. He's fine also with me. So this is how Hodgkin's, non-Hodgkin's lymphoma, Burkitt's and non-Burkitt's lymphoma present. They get abdominal masses that grow very rapidly, and that's what their presentation is. Okay, then we get to neuroblastomas. Okay, after CNS and lymphomas, okay, this is the third most common solid tumor. It's the most frequently diagnosed neoplasm in infants. Okay, and all of a sudden I learned that there's two kinds of neuroblastomas. Okay, fetal and infantile. What the hell is a fetal neuroblastoma? Well, basically, it's a tumor diagnosed on sonogram, and they see the lesion, on sonograms. So, oh my God, there's a lesion of a neuroblastoma is a lesion basically of the sympathetic nervous system. So that it's either anywhere in the sympathetic chain or on the adrenals. So they diagnose the adrenal mass. Great. Now the baby's going to be born with a tumor. What am I supposed to do? Except apparently these disappear. These disappear at birth, and they have no significance whatsoever. So why bust my chops with the diagnosis? Well, because it's there. Okay. The infantile develops after birth. Okay. So that basically it's a tumor that develops after birth. The median age of diagnosis is about 2 years of age. Okay. And again, I've had one. This one. It was a baby, and this was way before the anti-vaxxers. This was, an isolated lunatic. Okay. They weren't immunized for their kid. They decided no immunizations for their kid. And the kid was about 10 months old and came in with fever, lethargy, hyporeflexia in the lower extremities. Okay. And the father said, when I sat him up, I thought I felt something crack. I thought the kid had polio. Okay. Right diagnosis. I mean, he had all the right symptoms. Send him to the hospital. Full sepsis workup, please, including chest x-ray. Well, he had a fracture of T10 because he had a neuroblastoma that eroded through the thoracic vertebrae. When the father sat him up, he fractured the T10, so I shipped him off to the hematologist, never saw them again. But that was the only basic neuroblastoma I ever had. And the neuroblastoma, unlike others, they can develop blueberry muffin lesions, okay, which is possible, okay? But typically, in the early stages, a neuroblastoma is silent, okay? The most common presenting sign of a neuroblastoma is an abdominal mass, because it's along the sympathetic chain, or maybe it's an adrenal mass, okay? And if they produce, if it's an advanced malignancy, then they present with weight loss, fever, and anorexia, just like this kid did, okay? If they produce catecholamines, then you may wind up with hypertension and sweating. So it just depends on where the lesion is, what the symptoms are. But that's your neuroblastoma. Then we have a Wilms tumor. A Wilms tumor is a nephroblastoma. It's a tumor of the kidney. Again, young children under the age of 15, generally very young, 2 to 5 years of age, again, is how they present. And the most common presentation is the mother finds an abdominal mass in the kid. That's the most common presentation, basically, of a Wilms tumor, okay? But it's frequently associated with other abnormalities, okay? Remember the kid with the first slide I ever showed you, hemihypertrophy. The kid whose one side of his body was bigger than the other, that's associated with the possible development of a Wilms tumor, okay? Aniridia, absent of iris, okay? Hypospadias, increased incidence of Wilms tumor. So if you have a kid who's hypospadias or who presents with hemihypertrophy, one of the things that should go on in your head is that this may be um, a pre-warning of the kid developing a Wilms tumor. A recent study showed that it's due to a single epigenetic change in a single cell, okay? And that cell is supposed to suppress the H19 gene, okay? Because the H19 gene is responsible for the growth of kidney cells, and if you don't have the suppressor, then the kidney cells go wacko, and you wind up with a tumor of the kidney. So that's basically an renal tumor, okay, nephroblastoma. Now, what about bone tumors? There are two bone tumors common in children, an osteosarcoma and a Ewing sarcoma, okay? And when they get it depends on the age of the kid, okay? So the osteosarcomas are always over the age of 10. They're somewhere between 10 and 15 years of age. The Ewing sarcoma is in children under 10 years of age, okay? And basically, they both present the exact same way. The osteosarcoma is more common in males than females. It's the most common primary malignant tumor in children and adolescents. But these kids, the initial presentation, okay, generally, all right, is basically pain, maybe a joint effusion, tenderness, and warmth. That's how they present. And they are all athletes. The kids that I've seen with these, they're either softball players, volleyball players, soccer players, okay? They're all playing some sort of sports, and they come in with a swelling, tenderness, limitation of motion. So, of course, they have a joint injury because it happened after they were playing, whatever sport it was. So, what are you going to treat them with? You're going to treat them with rice, okay? Okay? So you're going to treat them symptomatically, and the only problem with these kids is they don't get better. Okay? And so after a week of their symptomatic treatment and then not getting better, okay, you send them for an x-ray. Then you get the hysterical phone call from the orthopedist. This kid has a bone tumor, okay? And the picture of the bone tumor has a sunburst appearance, okay? That's the typical picture of an osteosarcoma. It has a sunburst appearance. Now you're in trouble, okay? Now, the prognosis, if you catch it early enough, the success rate of cure is about 75% if it hasn't metastasized. If it hasn't spread, the prognosis is very good in these patients. The Ewing sarcoma, on the other hand, is in younger children. Again, pain, swelling, and limitation of motion. The one with the Ewing sarcoma I had was in his shoulder, okay? And he was pitching in Little League, okay? All right, so inflammation, we do the whole thing with rice and he doesn't get better. So very often these kids have undergone treatment for sports injury, osteomyelitis. They don't get better. You send them for an x-ray. You get the hysterical call from the radiologist. You got a bone tumor in this kid, and this kid's x-ray appears onion skin. So onion skin is Ewing sarcomas, okay? Starburst is osteosarcomas. This is typical of them. And again, if they're caught early, the success rate for that metastasis is high, is 75%. And the last one is this one. This is a rhabdomyosarcoma, the most common soft tissue injury of children. It can occur in any muscle. So it can occur again in head and neck, extremities, the trunk, okay? And it presents with a mass. And the mass may or not be painful, but it is not tender, it is not hot, it is not warm, it doesn't look like an abscess, okay? It's a mass. I've had two of these, both in the same family, and they run in families. This one. The first one was a boy who had an sternocleidomastoid. Okay, and it was resected, and he did fine. And then his sister came in with a mass like this. It was resected. It had spread to the femur. They did an amputation of the femur. Okay, and then she subsequently died. So again, this is one of these. If there's metastasis, the prognosis is poor. Okay, 80 to 90% cure rate. Okay, but if it spreads, it's a problem. So that's the osteosarcoma. Now the other thing is, I'll show you this one. This is just an infant organ swelling. The one I want to show you is this. Okay, this is why they tell you to look for the red reflex. Okay, well the red reflex ain't there right here. Okay, this is a retinoblastoma. This is why you look for the red reflex. Okay, and if it's not there, this side's got to go. Okay, this is typical of what a retinoblastoma looks like. All right, that's the end of hematology. So now we start the next to the last section, and now we're going to talk about the GI tract. And when we start with GI, even before we start with dealing with diseases, we have to talk about the microbiome. Have you had GI yet? Okay. We're spending a lot more time on the microbiome. And we're spending a lot more on the microbiome because we're learning more and more about how important the microbiome is. A recent study has shown that they can diagnose you developing type 2 diabetes from your microbiome before you develop symptoms. There was a study I just heard about done in India with babies born prematurely, and they studied the microbiome of these premature babies in India, and from the India microbiome, looking for one organism, they could determine which kid was going to die and which kid was going to live. So, I mean, there's lots of stuff going on with the microbiome, number one. And number two, okay, we're dealing with all sorts of stuff out there to make your microbiome better. Probiotics, prebiotics, symbiotics, okay? All this stuff is going to make your life wonderful and get you to live forever. And we'll talk about whether this is reasonable or not reasonable in the real world. So what does your microbiome do? Number one, your microbiome is basically unique. In fact, your microbiome is more unique than your fingerprints. Okay? I don't see the police testing people, for crimes by going into their microbiome. But your microbiome is unique. Every gram of stool has 1 million different species, 1 million organisms, with 1,000 different species. So this is what the microbiome is, okay? And the microbiome has three major functions. The first one is a metabolic function, okay? And what it does is it increases fermentation to short-chain fatty acids, which acts to salvage energy. So if you have a very efficient microbiome, you have the tendency to become obese. If you have a very inefficient microbiome, you have the tendency to stay skinny. And they proved this with mice. They took mice with sterile microbiomes and they transplanted the microbiomes of obese mice into these mice, and they became obese. And they transferred the microbiome of skinny mice into these mice, and they stayed thin. So because the efficiency based upon your microbiome, okay, has a tendency to determine whether you're at greater risk of becoming obese or underweight. Okay, your microbiome affects folate and vitamin K production, promotes colonic growth, and affects satiety and caloric absorption. So that's the metabolic. Then there's the trophic function of your microbiome. Basically, it functions to maintain normal GI activity. So again, short chain fatty acids, which we said what the metabolic effect is, has a proliferative effect on the colonic epithelial and intraepithelial lymphocytes. So it has the ability to maintain the functionality of normal GI activity. And then there's a protective effect where it enhances mucosal barrier against colonization by pathogenic bacteria. It trains the mucosal immune system to recognize friend versus foe via T cell regulation, and it establishes the production of IgA and mucin, which prevents adhesion by pathogens to the GI tract mucosa. It also somehow interacts with the brain. There's an axis of gut-brain axis, and this is what your microbiome is doing. So basically, how do you establish it? Well, vaginal deliveries is of the infant, where the baby is exposed to mother's vaginal and fecal microbiome, okay, is how we generate our microbiomes. C-section children, okay, have a significant lower gut diversity of organisms because they're not coming down the birth canal like normal deliveries occur. So the question is, should we smear the baby once the baby's born by C-section with mother's vaginal and fecal secretions? That's not being done in this country, but it's being done in France. Okay? And then if the baby is fed breast milk, the contact with the mother's skin and breast milk also increases the microbiome. By 2 years of age, your biome is established. It's yours, okay? It's not the same as everybody else's. So the question then comes in, can we artificially augment the microbiome? Well, what are prebiotics? Okay? Prebiotics are non-digestible ingredients like D-glucose, D-galactose, excuse me, and acetylglutamine and L-fructose. These substances are resistant to stomach acid, so they pass through the stomach, and then once they get into the gut, okay, they're not absorbed because they're too big. So basically, they act as the food for your microbiome, fermented by colonic bacteria, okay, they break them down into more absorbable elements. They're used for bacterial growth, okay, and in theory, it increases the health of your microbiome by feeding them all this wonderful food, okay? And then we have giving people, okay, probiotics, okay? And probiotics are non-pathogenic live bacteria, okay? And the question is, do these help? Okay? The theory is by taking these wonderful non-pathogenic bacteria, it's going to stimulate changes in your GI microbiome. But the question is, are they your microbiome? Is that what's normally in your gut? We said there's 1,000 different organisms. How do we know the ones that we're giving you are the microbiome of your gut? And they did a study in Israel. Because basically, when you take antibiotics, everybody says you should take probiotics after the antibiotics because the antibiotics may have knocked out your microbiome. And here, take these probiotics. What are these probiotics? What's normally in your gut or what's not in your gut? And do taking these probiotics help or not help? Because this is the theory. Nobody's done extensive studies on this, whether it really works. And the study, okay, they did, I don't know how they did this, people are crazy. They did endoscopies and colonoscopies pre and post administration of antibiotics. And then they measured how long it took for your original microbiome to come back to normal after the antibiotics and the probiotics that we gave you. Okay? And basically, there were people called resistors who you gave the probiotics and they pooped it right out and they had absolutely no effect whatsoever. They were called resistors, okay? And the persisters were basically the probiotics that you gave them stayed longer, and because they stayed longer, it took a longer time for your own microbiome to come back to normal. So are you really helping yourself by taking probiotics after you take antibiotics? I don't know the answer to that, but there haven't been any studies, and the probiotics that they're giving you may not be very helpful. Now, there's lots of other theories around, okay, that probiotics inhibit proliferation of your normal microbiome. Well, if they ain't the same stuff, it's not going to happen. Also, theories involve that the microbiomes may help in immunomodulation after the susceptibility to and the course of allergic and autoimmune diseases. So they're using microbiomes without studies for everything under the sun, like allergy, eczema, and asthma, inflammatory bowel disease and Crohn's disease, irritable bowel syndrome, diabetes, and obesity, because it's going to help the immunoregulation of all these wonderful problems. Yeah, well, the problem is what product to use. How stable is the product? Some some of these probiotics have to be refrigerated. Others don't. How long have they been sitting on the shelf before you take them? How palatable are they? What's the dosage and type of organisms that we should use? Should they be with meals, after meals, or before meals? Okay, is it a single organism or a combination? Is the patient compliant, and how safe is it? All these haven't been studied yet, but let me tell you, you go on TikTok and there are people out there swearing up and down about how how probiotics save their lives. Okay, symbiotics are a combination of pre and probiotics. Now, there have been recent reports of microbiome manipulation. What do we mean by microbiome manipulation? Well, if you're having GI surgery and they're worried about you developing C. diff after the surgery, or you're on prolonged antibiotics, so you know you're going to be on prolonged antibiotics, and C. diff may be a problem, how are you going to prevent the patient from developing C. diff? And the current recommendations are stool transplants, stool transplantation for C. diff. Okay, what they do is they take your stool, okay, and they save it, and they either produce it in pill form, or they save it and they give you an enema after treatment with your own stool. So they're giving you back your microbiome, okay? And the American Academy of Pediatrics in 2023 reported guidelines for how to pick the appropriate donor for stool transplantation. And the treatment for success rate for C. diff with stool transplantation was 80 to 90%. So this is out there, okay? We talked about modulation of obesity. Yes, if you're obese and they wipe out your microbiome and give you a transplant of a microbiome from a skinny person, you will lose weight, because the microbiome is not as efficient, so you'll lose weight. So it can modulate obesity. They did it in mice, okay, and they did it in human twins, okay, and it worked, okay. They also did donor stool in autistic children that had significant GI complaints and had positive results in the GI complaints of autistic kids 8 weeks after the stool transplantation. So you're going to see a lot of stuff about stool transplantation, manipulation of the microbiome. More and more studies are going to be done. I said the last study I saw, they could diagnose the onset of type 2 diabetes before it happened. So this is out there. You're going to read more and more about it as time goes on. So when we talk about GI, what do we talk about? We talk about vomiting, we talk about diarrhea, we talk about constipation, and we talk about abdominal pain. These are the big things that, and pediatricians are the only people I know who can sit around, eat lunch, and talk about consistency, color, and quality of stools. Okay, because we deal with diapers all the time. Okay, so let's talk about vomiting. Okay, what the heck is vomiting? Vomiting is an active process in which there's strong contraction of abdominal muscles, leading to increased intra-abdominal pressure, elevation of the diaphragm, and emptying the contents of the stomach. Retching, on the other hand, involves thoracic musculature, not abdominal musculature, to try to empty stomach contents. What's regurgitation? Regurgitation is what babies do. Okay? You feed them, they smile at you, and they puke up all over. That's what babies do. Basically, it's an effortless expulsion of gastric contents, basically only occurring in infancy. Then what's rumination? What's a ruminant? What?
They chew their cud, they like spit up their food and then they like.
Yeah, they chew their cud. What animals chew their cud? What animals are ruminating? Cows, sheep, goats, camels, they're all ruminators, okay? They all vomit up their stomach contents, re-chew them, and swallow them, okay? Well, some children do that. And the children who are ruminators generally are severe mentally handicapped kids. Normally, you don't see this in normal children. And then we come to GERD, okay? Here we go with GERD, gastroesophageal reflux. Okay, and there's a difference between gastroesophageal reflux and gastroesophageal reflux disease. There's a difference between the two of them. Okay, and this is the effortless return of stomach contents into the esophagus. Okay, so basically, vomiting is a symptom, it's not a diagnosis. A differential diagnosis goes on. And the most common cause of vomiting in infants and small children is overfeeding. It is not GERD. Okay? When a mother comes in and says, my kid is spitting up all the time, and you put them on a scale and they gain 3.5 pounds in a month, okay, this mother is stripping this kid with too much formula, and that's why the kid is spitting up. It is not GERD. It's overfeeding. This is the most common cause of vomiting in children, okay? And the easiest way to make the diagnosis is you weigh the kid, okay? Now, we have acute vomiting. So acute vomiting may be due to infections, viral gastroenteritis, bacterial gastroenteritis. It may be secondary to mechanical obstruction. But if it's due to mechanical obstruction, what is the vomiting like? Projectile. What does projectile vomiting mean? Everybody see The Exorcist? Remember the green vomit? The head spun around 3 times and the green vomit came out all over the priest? That's projectile vomiting. It hits the wall. That's not the kid pukes up all over everything. That's the one you worry about with projectile vomit. Trauma and toxins can do it. Metabolic diseases can do it. The inborn errors of metabolism. And then any extraintestinal disease. A lot of intestinal disease, extraintestinal diseases, illness outside the GI tract presents with vomiting. Meningitis presents with vomiting. Okay? Renal disease can present with vomiting. Sepsis, meningitis, urinary tract infection, pneumonia can all present with vomiting. Then we have Rye syndrome. What's Rye syndrome? That's why we don't give aspirin with children with chickenpox or the flu. Aspirin. It's basically an involvement, fatty degeneration of the liver and brain. Okay? Did I ever tell you how we treated Rice syndrome in the Dark Ages? In the Dark Ages, there was a period where we had an epidemic of Rice syndrome, and we had a young lady came in and stage 3 coma with Rice syndrome, and someone read an article of total body exsanguination for the treatment of hepatic coma. Gee, we should try this. The kid is in hepatic coma. We should try total body exsanguination for the treatment of it. There was no ethics committee that there is today. We didn't worry about the cost of anything. So we went to the parents and we said, listen, this is what we want to do. We want to take your daughter down to the OR. We want to put her on bypass. We want to lower her body temperature to 92. And we want to run water through it till her hematocrit drops to 1. And then we want to put fresh blood in. We want to do an oil change. Okay? And this was before the HIV epidemic, so there was no problem. And they said yes. So we took the kid down to the OR. There was 2 thoracic surgeons, a bypass team, and 2 intensivists in the OR. We dropped the temperature down to 92. We ran lactated ringers through her, okay, and empty her blood into a garbage pail, okay, and then put fresh blood in and brought her back upstairs. And she woke up from stage 3 coma in the elevator on the way back asking for pizza. So it worked. And we presented the results at the First World Congress on Gastroenterology. It'll never happen today because no insurance company in the world would pay for any brainstorm like this. And for 20 years, I got Christmas cards from this family. So, I mean, this was the Dark Ages of medicine. Today, we treat it with attempting to reduce intracranial pressure and symptomatic treatment. And you probably won't see Rice syndrome. And Rice syndrome was first published in 1919. It wasn't something new. We knew about it for a long time. The association of aspirin and the flu, we didn't know about until it was used. So as long as you don't give kids aspirin, you'll do fine. So that's acute vomiting. What about chronic vomiting? Okay. Well, gastroesophageal reflux is the most common disorder of the esophagus that may lead to vomiting in infants. Okay. It is a benign, transient abnormality. Okay? It begins in the first few months of life, peaks around 3 months of life and 4 months of life, and by 12 months of life is generally gone in 90% of the patients. 10% may continue to spit up until they're 2. Okay? These are babies who just spit up all the time. And basically what I say to the mother, okay, is when the kid pulls himself to stand, it will stop. Why? Because the kid pulls himself to stand between 10 months and a year of age. And I just told you, 90% of them will disappear at a year of age. These kids gain weight. They're happy. They have no symptomatology whatsoever. This is plain simple gastroesophageal reflux. It does not require treatment. Tell the mother to do laundry. Now, if the kid has a failure to thrive, is not gaining weight, evidence of esophagitis, meaning irritability, arching, choking, gagging, refusing feedings, or is having apneic episodes or aspiration pneumonia, these are the kids you want to treat. So you do not treat every kid that spits up. Okay? And basically, there has been no evidence to support the empiric trial of PPIs in infants who are asymptomatic. Okay? In older kids, as they get older, okay, you may want to try PPIs for GERD symptoms. So, GERD, gastroesophageal reflux, okay, does not have to be treated. GERD, gastroesophageal reflux disease, where the patient is symptomatic, those are the ones we treat. Okay? So, how do we treat them? Okay? Well, the symptoms of disease may be caused by things like rumination, but that's in neurologically impaired children, or achalasia. And achalasia is not GERD. And achalasia wakes people at night, okay, with this because it's a smooth muscle disorder. Okay, the gastric sphincter stays closed, so when you eat dinner and the sphincter stays closed, you're going to get reflux symptoms, and this is not gastroesophageal reflux. Okay, so 80 to 90% of children with GERD don't have tight sphincters, their sphincters is relaxed. So it's a motor disorder. Other etiologies, okay, erosive esophagitis, functional dyspepsia, nausea, gastroparesis. Gastroparesis we see in adults, we don't see it in kids. It's a delayed emptying time of the stomach. Supragastric belching, esophageal spasm. These are all symptoms that may look like GERD. And the problem in infants, and why when infants have GERD, they vomit, because we said GERD is and into the esophagus, not necessarily vomiting. Kids have small esophaguses. They're not long like adults. So basically, the difference between GERD and vomiting is 2 centimeters. If the esophagus is 2 centimeters shorter, okay, they're going to vomit when they have GERD. If the esophagus is two centimeters longer, it's just going to come up into the esophagus and go back down. That's why it stops in older babies, because as they get bigger, their esophagus gets longer. They reflux into their GI tract, to their esophagus. It never comes out. You never know they're doing it, and they don't have any symptoms whatsoever. And why don't babies have symptoms in general? Okay, it's because acid production begins in the stomach 2 to 3 hours after you eat. How often do we feed a baby? Every 2 to 3 hours. So every 2 or 3 hours when acid is being produced, you're pouring milk or formula down into the stomach, which counteracts the acid of the stomach, so they don't develop symptoms of erosive esophagitis, okay? Because what's coming back up is non-acid milk, okay? So basically, proton pump inhibitors or antacids are not indicated in young infants because their GERD is not acid containing, they're not symptomatic, and that's the problem. So how do we treat the infants to prevent them from spitting up if they're symptomatic? The first thing we do is thicken the feeds. Now, the bad old days, we used to say 1 tablespoon of cereal for every ounce of formula. Well, if we're putting 1 tablespoon of cereal for every ounce of formula to prevent them from developing GERD, they're beginning babies who are morbidly obese. So now we use a gel mix in symptomatic patients, okay, which will thicken the feeds and keep it down and not result in excess calorie accumulation. Formula changes, maybe, okay? We never use H2 blockers anymore in children. We used to. We don't use it anymore because of the risk of malignancy with prolonged H2 blocker use. So we do not use it in young babies, okay? But if you're using antacid or PPI suppression, okay, it's not without risks, okay? PPI use may result in the development of C. diff or NEC, necrotizing enterocolitis in very small babies. Pneumonia is increased, decreased absorption of iron, calcium, magnesium, and B12 with PPI use, myocardial infarctions, kidney diseases, dementia. So the study in 1.3 million children showed that the use of PPIs increases GI, ENT, CNS, respiratory, and renal complications. So the message here is we do not use PPI in young children who are spitting up and who are asymptomatic. Okay? So, and celiac disease has also been reported as a cause of increased protein pump inhibitor use. Okay? So again, this you should be aware of. Now, people have blamed GERD on H. pylori. Okay? And there have been studies done with endoscopies and aspiration to see if H. pylori was there. Okay, and the studies have been empiric. There's no studies been done to show that the diagnosis of H. pylori and H. pylori treatment were effective on the treatment. Okay, in older patients, PPIs may be indicated. Bronchoscopy, endoscopy, I mean, should be done in older patients with repeated GERD to rule out an esophagitis. Okay, and pH probe is not effective either. So that's the story about GERD. Again, it should, if you're going to treat it, you should be very careful of how you treat it. Now, there's something called cyclical vomiting. And cyclical vomiting is recurrent episodes of vomiting, meaning 9 per year, and in between they're perfectly well. Okay, usually it begins between 3 to 5 years of age, so it's on older children, and it lasts for 8 to 9 years. Okay, the cycles usually subside by adolescence, rarely present into adulthood, and it may result in some of these kids in significant dehydration requiring IV fluid. Okay, frequently this is thought to be a variant of migraine. It may be like an abdominal migraine or what have you. It's precipitated by stress, infection, lack of sleep, which is the same thing that predisposes people to migraines. So if you have a kid with cyclical vomiting and a strong history of family migraines, again, this is what you should consider. And the treatment for cyclical vomiting is amitriptyline or cyproheptadine, which we also use for the treatment of migraines in children. So again, it's not very common, but if you have a kid like this, cyproheptadine works. That's vomiting. Next on the hit parade is diarrhea. Okay? An excessive loss of fluid and electrolytes in the stools. So acute diarrhea is infectious. And we got lots of infections causing diarrhea. I mean, now we have a new one out there, okay? Cryptococcus in lettuce and all this other stuff. That's the latest one, okay? One of the most common causes of acute diarrhea is rotavirus in children, okay? Rotavirus, okay, it begins with contaminated surfaces with infected stool, begins 3 days post, the virus begins shedding 3 days post-infection, and it keeps shedding for up to 20 days in 70% of the patients, and for 60 days in 30% of the patients, okay? And in immunocompromised patients, it lasts longer. Rotavirus is the most common cause of diarrhea in young infants, and it was the most common cause of babies being admitted for acute diarrhea and dehydration. Now we have a vaccine, and I haven't admitted a kid for diarrhea and dehydration in years and years. Then we have norovirus, the leading cause of diarrhea infections for all ages. 20 million cases every year, with 70,000 hospitalizations and 800 deaths, particularly in the young and the elderly. This is the infection that you read about, okay, on cruise ships, okay? Because everybody goes to the buffet, they handle everything. Somebody who doesn't wash their hands after having a bowel movement, okay, touches every single thing on the buffet, and they infect everybody on the boat. And what do they have before the buffet, before you get there? Right? They have alcohol dispensers, right? To clean your hands, right? There's just one problem with that, okay? Alcohol foam does not protect against norovirus. The only thing that prevents against norovirus is soap and water, and there isn't a sink with soap before every buffet on a cruise ship. There's the alcohol foam, and everybody thinks they're safe, and they are not. So that's where you wind up getting norovirus, okay? Besides cruise ships, in the summer, public parks and beaches pose the greatest risk. Then we have salmonella. Where do we get salmonella from? Poultry, maybe. Uncooked poultry. Where else? Pets. Snakes, iguanas, turtles, lizards, and now guinea pigs. All can give you salmonella at home. They used to mail turtles through the mail. Okay? And there are people who keep turtles and lizards, iguanas in their house, and that may be a source of salmonella. What about Shigella? Shigella is nasty. Shigella can last 6 months in water, 30 days in food. It can exist on the toilet tissue in the bathroom and on the toilet seats of an infected individual, and only requires a very small inoculum, and that's one of the causes of bloody diarrhea. And then we have Campylobacter. Not very common in this country, okay? A small inoculum is needed, and where do we get Campylobacter from? Dogs, cats, cattle, sheep, undercooked meat, poultry, and raw milk. Other than infections, toxins, drugs like diuretics and xanthine can do it. C. diff can do it. Bowel obstruction, vascular compromise of the gut, and parasites. So when somebody calls you up and tells you, my kid has diarrhea, okay, how are you going to treat them? What do you tell the mother to do for a kid who has diarrhea? I'm waiting for somebody to say it. Yeah, that's the brat diet. We no longer use it. The brat diet is bananas, rice, apples, and toast. And what that essentially does is starve the kid to death. Okay? And when you starve the kid to death, okay, you get chronic nonspecific diarrhea. So we don't treat diarrhea with the brat diet. Okay? Basically, okay, you want to provide adequate fluids, calories, and electrolytes. So you feed them. The higher the fat in the diet. When they have diarrhea, they can have milk. Giving a kid with diarrhea milk? What are we, crazy? Why don't we give the kid with milk diarrhea? Why didn't we give the kid milk with diarrhea? I mean, where the hell did that come from? Don't give the kid milk when he has diarrhea. Why? What was everybody afraid of having? What? Lactose intolerance. Where is the lactase enzyme in the GI tract? In the mucosal line. The only way you're going to get a lactose intolerance from diarrhea, okay, if you slough your mucosal lining of your gut. So if a kid has cholera and rice water stools, I wouldn't give them milk, okay? We don't have cholera in this country. So you want to give them milk because it's high in fat and calories. And let me ask you a question. Which slows up your gut more? A high carb meal or a big fatty meal? Which lays longer? The big fatty meal lays there forever. Isn't that what you want to do? You want to slow up the gut. So you increase. So I tell the parent, give as much on top as comes out the bottom. Give them anything they want to eat. The higher the fat, the better. Give them milk. Give them macaroni and cheese. Give them anything high in fat. It slows up the gut, and that's how we treat it. You want to first do no harm by giving them the brat diet, starving the kid, and you're giving them more problems. Okay. Now, do you want to give them medicine that slow up the GI motility? Okay, you want to give them Imodium or Pepto-Bismol or anything like that? Why do you want to slow up a gut that has inflammation and it's trying to get rid of it and you're trying to keep it there longer? That makes no sense to me at all. Okay, so you load them up on food and they do better. Oh, here's a question. How do you tell if mother calls you up, my kid's vomiting, he's puking up everything else. All right, what's the first question I ask for both of these? Vomiting and diarrhea. What do you want to know? First question. Is the kid urinating? Because if the kid's urinating, I know he's not dehydrated. and then I don't have to worry about dehydration. So if the kid has diarrhea and he's urinating, then feed him everything and let me know if he stops peeing. Okay? But vomiting is different. So how do you treat a patient who's vomiting? Mother calls you up. My kid's puking everything I give him. Okay? What do you tell the mother to do? What advice are you going to give him? Anybody? Okay. You want to, number one, rest the stomach. So they get nothing to eat or drink for 2 hours. That's number one. Because anything you pour down an inflamed stomach is coming right back up again. Okay? Nothing to eat or drink for 2 hours. Then you do not say give them small amounts of fluids because one mother's small amount is a tablespoon and another's mother's small amount is 3 ounces. So you never give them, you never say start with small amounts of fluids. No, you don't do that. Nothing to eat or drink for 2 hours, and then it's 1 tablespoon of clear fluids every 15 minutes for an hour. And if that stays down in an hour, then it's 2 tablespoons of clear fluids every 15 minutes for an hour. And if that stays down, it's 2 or 3 ounces at a time, and they get no food for 6 hours until they haven't vomited for 6 hours. And then you're going to get, oh my God, no food for 6 hours? They're going to starve to death. And my answer is, if I put them in the hospital, I'm not putting mashed potatoes in the IV. I'm only giving them fluids. So, and then I haven't admitted a kid to a hospital for vomiting, and I can't tell you how long if they listen. Okay? You start slowly, you increase slowly, no food for 6 hours, and then you say to them if they call you for vomiting, tomorrow the diarrhea is going to start. Because if they ever get gastroenteritis, it starts with vomiting, and then the diarrhea starts. And how long is the diarrhea going to last? You better say 10 days. It's usually less. Okay? But if you say 3 or 4 days, on day 5, you get the phone call. On day 6, you get the phone call. If you say 10 days, you don't get the phone call till 10 days. And by that time, they're better. And then if it stops at 3 or 4 days, he's stupid. He didn't know how long it lasts. That's fine. It saves phone calls. So that's the way you talk about acute diarrhea, and that's how we treat it. Okay? What about chronic diarrhea? Okay? Depends on age. Okay? Chronic diarrhea depends on age. Okay? During the first 4 months of life, okay, cow's milk and soy protein intolerance is the most common cause of diarrhea in young children. Post-GI malabsorption syndrome is rare. These kids don't get acute gastroenteritis. Cystic fibrosis may present as chronic diarrhea in the newborn period. If they've had surgery in the newborn period, then obviously that may be the cause. And then some of the rare congenital transport deficits. From 4 months to 3 years of age, the most common cause of chronic diarrhea is chronic nonspecific diarrhea, and we'll come to that in a minute. Cow's milk protein sensitivity, cystic fibrosis, Giardia. What the heck is Giardia? It's a parasite. Where does the Giardia live? Anybody know? What? It lives in the duodenum. Okay? If you want to look for the parasite, you have to do a duodenoplasty. If you think it's a parasite, you may start with stool studies to see if you can find the ova of the parasite. Okay? Celiac disease can also present in 4 months to 3 years of age. Above the age of 3, the common causes of acute diarrhea, chronic diarrhea, is Giardia, celiac disease, and now we talk about inflammatory bowel disease. Okay? The youngest patient I ever diagnosed with inflammatory bowel disease was 18 months old. Okay? And then irritable bowel syndrome, which is really a garbage pail and extremely difficult to treat. So we said chronic diarrhea, the first one is chronic nonspecific diarrhea. This is the single most common cause of diarrhea, complaint of chronic diarrhea in children and infants between 6 months and 3 years of age. This is the peak for chronic nonspecific diarrhea. And the history is classic. They start with watery, dark green, large stools, generally early in the morning and after a large meal. And as the day goes on, the diarrhea gets less and less and less, and it stops at night. They never get up with diarrhea. The next morning, it starts all over again. Large, watery, green diarrhea, and then gradually, as the day goes on, it disappears. These kids are perfectly normal. Their activity is normal. Their weight gain is normal. Their linear growth is normal. Okay? The pH of the stools are negative for carbohydrates, which rules out a disaccharide-based intolerance like lactose, fructose abnormalities. Okay, there's no blood and there's no white cells in the urine and the stool, which rules out inflammation. Okay, if the pH of the stool is alkaline, you may want to think of lactose intolerance. Lactose intolerance. Excuse me. The pH of the stools in chronic nonspecific diarrhea is alkaline. If it's acidic, you want to think of lactose intolerance. Okay? It frequently begins after a stressful situation, antibiotic therapy, okay, a viral illness, or somebody put this kid on a brat diet for the treatment of their acute diarrhea, and now they have chronic diarrhea after you've been starving them to death with the brat diet for their acute diarrhea. Okay? And what happens is, if it's iatrogenic due to the brat diet, these kids eventually are being starved. They will show caloric deprivation and weight loss. So, how are you going to make the diagnosis of chronic nonspecific diarrhea? One, by the history of what the stools are like. Two, by what your knowledge of the family is. The family has a history of functional abdominal complaints. You know how all you have to do is listen to people talking, and you know they have a history of functional abdominal complaints. This is the typical conversation. Did you hear about so and so? I heard about what happened to her. I'm so upset it made me sick to my stomach. Ding, 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 ding. These patients take every stressful situation and turn it straight to their GI tract, and now they have functional abdominal complaints. And all you have to do is listen to the way they talk, and you know this is what they do. Other patients, okay, it gave me such a headache when I heard all about that. These are the people with migraines. Okay, so if you listen to people talking, you're going to find out a lot basically about their lifestyles. Okay, number one, these kids tend to be fair-haired and fair-skinned. Recently, they're reported they tend to be generally hyperactive, and the level of parental concern about something terribly being wrong to their child, okay, despite the fact that he's growing normally and has no problem whatsoever, they think this is a major threat to his health. Okay? So basically, how do we treat these kids? Well, number one, we reassure the patients that your kid is growing and doing fine, and we're going to give you some things to help him get better. Number one, we are going to increase the fat in his diet. Less carbs. Two, only fluids at room temperature. No ice cubes, no cold fluids, because the minute you pour cold fluids into the stomach, you're going to trigger a response, and he's going to get the diarrhea. And he gets 3 to 4 meals a day and no snacks. Why isn't he allowed to have snacks? Generally, what are snacks? They're carbs. And I just told you to increase fat in his diet and not give him carbs. So if your kid snacks on a half a pound of butter, be my guest. But otherwise, no carbs as snacks, 3 to 4 meals a day is how you treat this patient when you're treating him for chronic nonspecific diarrhea. Okay? And this you will definitely see. Celiac disease, Oh, here we go. Celiac disease is a comic of chronic induced diarrhea. What is celiac disease? It's a gluten-induced enteropathy. Okay, it's an immune-mediated disorder, and it results in proximal small bowel damage, and it's triggered by gluten and related proamines in genetically susceptible individuals. Okay, it's an inflammatory enteropathy. It has CD-specific antibodies with a wide range of GI and systemic complaints. How common is celiac disease? Do you know what percent of the population has celiac disease? 4% of the population, which means it's as frequent as Down syndrome. If you go to the supermarket, okay, you would think half the population has celiac disease because of all these gluten-free products that are out there. And gluten-free products, we will talk about this in a minute, are not healthy. Okay? The common age of presentation for celiac disease is 6 months to 2 years of age. Okay? It's about, the incidence is about 1 per 1,000 live births in those of Northern European ancestry. The typical presentation of celiac disease is diarrhea, failure to thrive, maybe vomiting and irritability, okay? But their stools stink to high heaven, foul smelling. There's weight loss, abdominal bloating, or pain. Occasionally, oral after constipation and rectal problems. Extraintestinal manifestations of celiac disease, malnutrition related. If you don't get enough calories because you have the chronic diarrhea, you're going to have short stature, failure of vertical growth, delayed puberty, iron deficiency anemia, resistant to iron treatment because if you have malabsorption, you're not absorbing the iron, oral stomatitis, liver and biliary tract disease, skin disorders, and joint symptomatology, arthritis and arthralgia. 60% of patients with celiac disease also have juvenile rheumatoid arthritis. Okay, and in addition, type 1 diabetics frequently also have celiac disease. So if you have a type 1 diabetic, you should screen them basically for celiac disease, okay, to rule it out. All right. They also may develop neurologic problems, headaches, peripheral neuropathies, ataxia, seizures, behavioral issues as well. Diagnosis of celiac disease, okay. Number one, there are 3 blood tests, anti-endometrial antibodies, anti-gliadin antibodies, and tissue glutaminase sensitivity. Those are the 3 blood tests. Of all of them, okay, the tissue transglutaminase is the test you want to do. Why is that the one you want to do? Because if you're looking for anti-endometrial or anti-gliadin antibodies, which are IgA antibodies, most patients with celiac disease are IgA deficient. So if they have celiac disease, they're not making IgA antibodies. I mean, some of them may, but many of them won't. And if they don't have IgA antibodies, okay, even if they do have celiac disease, you're not going to find it. But if you're really going to diagnose celiac disease, they need a small bowel biopsy. Okay? What does a small bowel biopsy show? Okay? What's the pathophysiology of celiac disease? Okay? It's shortening and flattening of the villi of the gut. So if your villi is sticking up in the gut, okay, like this, and they're traumatized by gluten in the diet, they become shorter and shorter and shorter, okay, which means their absorptive surfaces are decreased. That's why they're having diarrhea, because they can't absorb what they're ingesting because the villi, the intestinal villi are blunted and shorter. So you need the biopsy to cause it. Now, there are current mimics of celiac disease. One is a wheat allergy. I mean, you can be allergic to wheat and not gluten sensitivity. What the hell is gluten anyway? What's gluten? Okay, where do we find gluten? We find gluten in every grain except rice. We find gluten in wheat, barley, rye, okay? That's where we find gluten. What does gluten do? Okay, what foods are high in gluten? What are the two biggest foods high in gluten? Bagels and pizza. Okay, what does gluten do? Okay, okay, gluten, you never see a guy making pizza and he's able to stretch pizza like this? That's gluten. If there was no gluten and you try to stretch any flour, it would fall all over the floor. Okay? When they used to make bagels, before they had machines, okay, they would roll out the dough into a long tubular thing, and the bagel maker would take the dough and wrap it around the stump, pinch it off, wrap it around the stump, and pinch it off. So in the bad old days, when you wanted to buy bagels, you wanted a big fat bagel maker. Because the bigger the stump, the bigger the bagel. Okay, because it was wrapping it around a fat thumb rather than a skinny thumb. Okay, so that's what gluten allows flour to do. It allows you to stretch it. Okay, so if you're allergic to wheat, you're allergic to all wheat, and it's not gluten that's doing it. Okay, and how do you know whether you're allergic to wheat? Generally, you can wheat allergy is mediated through mast cell IgA sensitivity, and you can have a wheat allergy by exposure to wheat, not just by eating it, basically by skin contact or inhalation. So if you have somebody who hasn't presented with celiac disease when they're younger, and all of a sudden they have problems eating wheat with diarrhea or what have you, skin test them. If they're allergic to wheat, they don't have celiac disease, they just can't eat wheat, and they can probably eat other grains. Non-celiac wheat intolerance is a very poorly defined syndrome. It's a barrier combination of intestinal, extraintestinal symptoms, okay, that occur after gluten-containing foods and may disappear after withdrawal. It's not very common. 0.6 to 6% of adults may have it, and basically the treatment is you eliminate all gluten products or you eliminate just wheat. And if you eliminate just wheat and they get better, then you know it's non-celiac wheat intolerance. You know what FODMAP is? FODMAP. Okay, FODMAP is short chain carbohydrates that are not absorbed. Trying to treat this is a pain in the butt because when these people eat short chain carbohydrates, and what are they? Basically, we're talking about fructans, galacto-oligosaccharides, disaccharides, meaning lactose, monosaccharide, fructose, sorbitol, and mannitol. These all ferment in the gut because they're not absorbed. And because they ferment in the gut, they give you diarrhea, bloating, gas, and what have you. Okay? Well, trying to eat a diet that doesn't contain any of the thing is a very restricted diet and very difficult to treat. Okay? It's a pain in the butt. But these people do not have celiac disease. So let's talk about here in the United States. 2.7 million people in the United States are on a gluten-free diet. The claim that 10 to 15% of Western population have a wheat intolerance has not been substantiated. Since I said only 4% of the population really have celiac disease. So here's the reason people give. I'm eating a gluten-free diet because I think it's healthier, number one. I want to lose weight, number two. And then to relieve GI symptoms, extra GI symptoms, and only 5% are on it to rule out celiac disease. Now, here's the problem, okay? Is it healthier? Well, we take all the gluten out in something like bagels or pasta or anything else. What are we replacing the gluten with? Carbs. Okay, so an typical English muffin has 120 calories. It has 25 grams of carbs. It has 1 gram of fat and 1 gram of fiber. A gluten-free English muffin has 210 calories because now it has 35 grams of carbohydrate and 3.5 grams of fat. So you're going to lose weight on that? I don't think so. Okay, so all the people who are on it thinking that they're going to lose weight on this wonderful gluten-free diet. Okay, and there's, I'll give you an example. Italy consumes 160 pounds of wheat per person per year. Here in the United States, we consume less than 80 pounds of wheat per person per year. So we consume half the amount of wheat that they do in Italy. The incidence of obesity in Italy is less than 10%. The incidence of obesity here in the United States is greater than 50%. So you ain't getting thin by eating a gluten-free diet. Okay? In addition, a gluten-free diet, okay, like this. A gluten-free diet also has cadmium, arsenic, lead, okay, are all present in the gluten-free diet. And there was an article in last year saying gluten-free diet for celiac disease may increase arsenic exposure in children. So while you're treating their gluten-free diet, okay, you may be poisoning them with heavy metal poisoning. So this is out there as well. So again, you shouldn't diagnose celiac disease unless you really had a renal biopsy, small bowel biopsy, to look for the intestinal villi, not because of the symptoms. That's the message. Okay. Now, what about inflammatory bowel disease? Okay. Well, we have Crohn's disease, okay, which is through and through, mouth to colon. And then we have ulcerative colitis, which is just the lower part of the GI tract. Okay. Well, there is also an intermediate between the two. And what's the pathogenesis of inflammatory bowel disease? We believe it's an imbalance between pro and anti-inflammatory regulatory cells. You get activation of T cells in the lamina propria of the GI tract, resulting in recruitment of inflammatory cells from the circulation. Things like IL-3 cytokines are switched on, which produce pro-inflammatory CD4 and T4 cells, which accumulate in the inflamed intestine and worsen the disease. Okay? So basically, normally you can have bacteria in the gut, you have a mucosal barrier, there's some sort of trigger, an environmental trigger, okay? There's a mucosal immune response, okay? And then you get healing. In acute inflammatory disease, this doesn't happen. So what's the etiology? Well, is it genetic? Is it environmental? The incidence of inflammatory bowel disease is about 400 per 100,000 population. Crohn's is more common than ulcerative colitis. Okay, in 1900, it was only 1 per 100,000 population. So why the heck are we seeing so much inflammatory bowel disease now, when in the 1900s we were only seeing 1/400th of what we're seeing now with inflammatory bowel disease? Okay, and this again is the hygiene hypothesis. Okay, we're too clean. Okay, so we have our body creating inflammatory responses to normal environmental triggers. Okay, if there's a family predisposition, about 11%, it's a polygenetic disease. 15 to 20% have a family history. The rest of the family does not. We know chromosome 16 is associated with Crohn's in Caucasian only, but the same We used to think that it was only it was emotionally triggered and it was only seen with people living in the cities. The people on the farms never got it. That's because they were exposed to all the environmental triggers that the people in the city weren't. Okay. And again, now it's city and urban, it's the same. So you have a normal gut, you have an environmental trigger, acute injury and healing. End of the question. With inflammatory bowel disease, you have a normal gut, you have an environmental trigger, acute injury, loss of barrier tolerance, chronic inflammation in the genetically predisposed, basically, patient. Okay? So, what are the manifestations of inflammatory bowel disease? This is a disease of young adolescents. We don't really see it in young children. And the hallmark of inflammatory bowel disease, okay, is abdominal pain, weight loss, and blood in the stool. This is how they present. If you saw this adolescent on a regular basis before they went away to college, okay, and you saw them on a monthly visit or every few months, 50% may have had a documented a growth failure prior to the onset of the disease. Their growth rate has slowed. But adolescents don't get sick, so we only see them once or twice a year, so it's very difficult to measure growth failure. Okay? 20%, 20 to 40% of these patients will have significant linear growth retardation into adulthood. Crohn's disease, 85% will have a decrease in growth velocity. So, what's your workup? Well, basically, you want to do a CBC, sed rate, urine analysis, metabolic profile, coagulation profile, serum albumin, serum iron, because most of them are anemic, stool culture for pus cells, white cells, culture for ova and parasites, and the big test is the fecal calprotectin. Okay. The fecal calprotectin, if it's greater than 50 micrograms per gram of stool, that's considered positive. Most of the kids with inflammatory bowel disease are going to have serum calprotectin greater than 400. Okay. If it's negative, it's predictive. Okay. If your fecal calprotectin is 0, okay, you don't have inflammatory bowel disease. If it's positive, it's not predictive because 20% of patients referred to GI for elevated calprotectin do not have inflammatory bowel disease. And then what's your workup? Well, I mean, you can do x-ray studies, but nowadays, if you suspect inflammatory bowel disease, okay, these patients get an endoscopy. This is the gold standard. You get an endoscopy to see what the heck basically is going on. That's what you want to know. Now, treatment, I am not going over the treatment. That's for the GI people to how to treat them. I will tell you a real bizarre treatment for inflammatory bowel disease, okay? And that's the pig whipworm, Trichuris suris, okay? Because in France, somebody did a study and realized that pig farmers never ever get inflammatory bowel disease. And all pig farmers are chronically infected with the pig whipworm. So he came up and said, well, what if I give these people the eggs of this parasite? Will it cure or their inflammatory bowel disease? And he gave these people 2,500 eggs every 3 weeks for 24 weeks. And 23 of 29 patients got better. Why? Because we said that basically your inflammatory bowel disease is your inflammation turned on and gone screwy. Well, apparently, when the pig whipworm eggs hatch, they turn off the inflammatory process of your GI tract and the symptoms go away. Okay? There was a second study for ulcerative colitis. okay, where 13 of 30 improved and only 4 of 24 improved. So just Google worms and inflammatory bowel disease, and you will find this because these eggs do very little harm to the individual. They just are hatched in your gut, and they turn off your inflammatory response. If you're interested in worms and treatment, there's another lunatic out there who decided that his asthma, they didn't have asthma in Papua New Guinea. And everybody in Papua New Guinea is chronically infected with hookworm. So say, well, maybe the hookworm turns into the inflammatory response for asthma. So he went to Papua New Guinea and he infected himself with hookworm and his asthma got better. So then he started selling his stool online to asthmatics to infect them with hookworm. But hookworm is very different. Hookworm will turn off your inflammatory response, but will make you very anemic. So periodically you have to kill all the hookworm and then start over again. But this was another one. You know, how does a tapeworm live in your body? If you're infected with a tapeworm, why doesn't the body get rid of it? Because the tapeworm has figured out how to attach to your intestinal mucosa and turn off the inflammatory response. And as soon as one drug company figures out what the tapeworm does to turn off the inflammatory response, they're going to make $1 million because they're going to make a pill to give you what the tapeworm does. So if you can turn off the inflammatory response, it works. So, and I know there are some GI people, there's one group of Great Neck that is using the whipworm on their resistant inflammatory bowel disease. Okay, and the last, we'll talk about constipation. Okay, and we have a definition of constipation. Constipation is the passage of hard and infrequent stools. Infrequent stools are normal. Infrequent bowel movements, if they're normal for you and you don't have pain or difficulty and you have normal bowel movements to go once every 2 or 3 days, you're normal. You do not have to go every single day, despite what your grandmother says. Okay? And then there's encopresis, which is the passage of stool in inappropriate places, like kids having fecal soiling in school beyond the age of 4. That's encopresis. We'll talk about that in a minute. We have functional constipation. I told you breastfed infants can go every 7 to 10 days and be perfectly normal. And then we have a kid, childhood kid, okay? And when we're toilet training, and what are we telling them to do? Don't have a bowel movement in the diaper whenever you want it. Hold it and have it in the potty. And then we have the battleground for parental discipline and supremacy. You have to have a bowel movement in the potty, and the kid's saying, I know how to make mommy crazy. Okay? And this is where the battle goes on. Okay? And if you have a compliant kid and he holds back and doesn't have a bowel movement whenever he feels like it, the stool tends to get larger and it's more uncomfortable to pass. Why the hell should I do this? Okay? And if he holds back long enough, okay, the stools become bigger, harder, and more difficult to pass. So he holds back even more, okay, to avoid the pain. And if he starts doing this, the more the stool is in contact with the distal large intestine and the rectum, more and more fluid is being absorbed, okay? And the stool gets bigger and harder, okay? The rectum becomes distended. It loses all sensation of having to have a bowel movement. And then the liquid stool from above comes down, flows around the hard, inspissated stool, okay? And now we have encopresis, okay? And that's what encopresis is with the overflow soiling. And the treatment for this, okay, is you got to empty the stool. You got to let the rectum come back to its normal size. Let the innervation to the rectum impose itself so the kid knows when he has to have a bowel movement and he doesn't have the soiling. Okay, and this can be a problem. You really have to empty out this kid's stool. Anal stenosis, or imperfect anus, okay? Obviously, if they don't have a rectum or an imperfect anus, they're gonna have constipation, okay? Um, if the anus is anteriously displaced, okay, it may be harder for them to pass stool. It may result in constipation also. Then we have abnormal musculature. Did you ever hear prune belly syndrome? Prune belly syndrome is the absence of the transverse abdominis muscle. So the kid's belly looks like a prune, all wrinkled, because you don't have the muscle. Okay? So if you don't have a transverse abdominis muscle, it's a little difficult to increase intra-abdominal pressure to help have a bowel movement. This is prune belly syndrome. Gastroschisis is a vertical defect in the abdominal wall between the rectus muscles, and again, it's difficult to bear down and have a bowel movement. And Down syndrome kids tend to suffer because they're hypotonic, and if they're hypotonic, they have difficulty with bowel movements. And then there's Hirschsprung's disease. This is aganglionosis of the colon. It's an embryologic defect. Embryologically, during the development of the large bowel, the myenteric plexus, which innervates the wall of the large bowel, migrates down the large bowel. And the defect is it stops at one point. Okay? So the myenteric plexus stops. And wherever it stops, there's no innervation, basically, to the large bowel. So basically, you can't have a bowel movement. Okay? So who do we suspect Hirschsprung's disease on? Any kid who doesn't pass meconium in 48 hours after delivery has Hirschsprung's until proven otherwise. A kid who fails to gain weight after delivery may have Hirschsprung's. If he has gross abdominal distension, or if the mother tells you that when he passes stools, that ribbon or toothpaste line. And when you do a rectal exam, there's no stool in the rectal ampulla. Okay? This is typical of Hirschsprung's disease. Okay? The treatment for it in infancy, they do a colostomy. And then as the kid gets older, they go in and they resect. Basically, when you do a barium enema on these kids, you'll see distended stool up to one point, and then the stool comes back to its normal functioning. That's where the myenteric plexus stops. When they get older, they resect the stool, pull the normal stool down, attach it to the rectum, and they're cured. Now, if you want to be a genius, okay, this is one of these rat facts that you put in the back of your head. Anybody who has a baby who presents with Hirschsprung's disease, you want to rule out them having multiple endocrine neoplasia, typically thyroid carcinoma. Okay? And I had a family in mind. The father's brother had a baby with Hirschsprung's. And one smart doctor asked the father's brother, anybody in the family has thyroid cancer? Oh yeah, my father had it. Everybody in this family should be checked for thyroid carcinoma. He calls his brother, as the father of my patient, and he says, we have to be checked for thyroid carcinoma. The father was checked for thyroid carcinoma and had it, and had a thyroid resection. His oldest son was screened for thyroid carcinoma and had it, and his thyroid was resected. The oldest son's daughter, who I'm taking care of, was screened at 5 years of age and had pre-thyroid carcinoma, and her thyroid was resected. All because somebody said to a person who has Hirschsprung's disease, okay, is anybody in your family have thyroid carcinoma? So this is the one rat fact that you put in the back of your head, okay? And you'll be the genius and save this family a lot of grief down the line, okay? The spinal cord defects spina bifida, tether cord, spinal cord trauma, obviously will give you constipation. And then you know about drugs, right? Anticholinergics, antacids, narcotics. Well, narcotics cause constipation. There's commercials on television. Do you take narcotics and are you constipated? Okay. Antidepressants, vitamin D, intoxication. Heavy metals can all result in constipation. Um, Barium, anybody who's had a barium enema knows that they're constipated forever after that. Okay. Bismuth. Bismuth causes constipation. Sure, why do you take Pepto-Bismol if you have diarrhea? Because Pepto-Bismol can cause constipation, so you use that. The rarest cause of constipation, okay, is basically iron. Iron supplementation does not cause constipation, okay? Then we have, okay, basically metabolic disorders. Connective tissue disorders can do it, okay, like scleroderma and lupus, and then psychological etiologies for constipation can also do it, okay? And the last thing we'll talk about is chronic constipation. Oh, great, chronic constipation. 9.5% of the population have chronic constipation, and this is a functional defecation disorder. Okay, it begins at 2 to 3 years of age. Why does it begin at 2 to 3 years of age? Because that's when they're toilet training the kid. Okay, what's the definition of chronic constipation? 2 of the following for more than a month. 3 or fewer bowel movements per week. Stool retention. Painful or hard bowel movements. Large diameter stools. Large fecal mass in the rectum. More than one episode of fecal incontinence, and a history of stools that are so large that you have to call the plumber. Okay, and there are some kids, trust me, every time they have a bowel movement, they stuff up the toilet. Okay, now, what you do not do for chronic constipation, one, you don't take an x-ray. Because studies have shown that they've shown x-rays of a constipated patient to radiologists, asking them for their opinion of constipation, okay? The agreement between 2 or 3 radiologists on whether this is significant for constipation is very low. So making a diagnosis on x-ray of constipation is not helpful, okay? What's the relationship between hypothyroidism, hyperparathyroidism, celiac disease, okay? Because patients with celiac disease have diarrhea. They usually don't have constipation. Occasionally, hypoparathyroidism complains of constipation and hyperparathyroidism. But that doesn't mean the hyperparathyroidism and the hypothyroidism are causing the constipation. Association is not causation. And we went through this statement once before. Remember I told you about, what's his name? The movie actor, every time he stars in a movie, the drowning rate of the United States goes up, so we shouldn't let it appear in movies. Okay. Nicolas Cage. Every time Nicolas Cage appears in a movie, the drowning rate in the United States increases, so we should prevent it from appearing in movies because he's going, no, that's not the way that. Iron, studies of iron and constipation, okay, or diarrhea occur with the same frequency. You either get constipation or diarrhea with iron, okay? Studies of iron constipation in infants given iron, 1% of infants got constipation supposedly from iron, okay? And 9% with the placebo got iron. So obviously iron doesn't cause constipation in infants, okay? So you do not do $1 million workup for all these things for constipation. Okay, so how do we treat it? I told you this before. If you want a child to toilet train them, you reward them for sitting on the potty watching television, not for having a bowel. Because you reward them for sitting on the potty when you're toilet training them, then when they go on the potty, okay, it's just a normal part of being sitting on the potty. Okay, and you don't reward them for a bowel movement. You know why? What are you going to do with the bowel movement? You're gonna dump it down the commode and flush it away. Why should I give you a present that you're rewarding me for when you're gonna throw it out? Okay, that's ridiculous. I'm not giving you any more of that stuff. Okay, so that's the first thing. Okay, there's no documented evidence that fiber increases the frequency, consistency, fecal incontinence, or abdominal pain, despite what you hear on the internet. There are no investigations in increasing foods in high natural fiber in the diet as a natural way of introducing in fiber and the effect on constipation. Okay, so guess what? All the fiber you're taking, there's no studies that works. Okay, how about water? Have you heard about drinking more water for constipation? Your constipation, the stool is hot. Drink more water, right? You've heard that. 90% of the water you drink is absorbed in the small bowel. It never gets down to your rectum. So drinking gallons of water is not going to help your constipation. It's only going to make you pee more. Okay? So that basically doesn't work either. Exercise has been shown to improve constipation. Okay? And then 2 fruits have been shown by studies to improve constipation. One is prunes, okay, and why do prunes work? Because they contain fiber, fructose, and sucrose. And what does fructose and sucrose do in the small gut? It draws water into the small gut and makes the bowel movement softer. And the other fruit that does it, okay, is kiwis. Okay, eating kiwis, okay, basically, when you eat kiwis, they swell a whole lot in the GI tract and they draw water into the gut, okay, and make the stool softer and what have you. So kiwis work. And then what's all the bad stuff about where are we? About treating constipation. Okay? Probiotics. Studies have shown absolutely no benefit of probiotics on constipation. Stimulant laxatives, okay, can be used, and we used to say don't give stimulant laxative because abuse of stimulant laxatives are going to destroy your gut. Studies have shown that stimulant laxatives do not damage the GI tract. You can use it, and the big one, and the one I use, okay, basically is polyethylene glycol. Okay, and first of all, to cure chronic constipation takes 6 months to a year. In fact, it takes as long to treat it as it took for you to get chronically constipated. Okay? 60% will improve within the first year of treatment, 30% will remain constipation well into adulthood, and the first thing you need to do is clean disinfection. So polyethylene glycol, antifreeze. Okay, it's this huge molecule that doesn't get absorbed. Okay, so it gets down to your GI tract, it draws water into your gut, okay, and loosens up your bowel. Now, everybody's upset about polyethylene glycol. Oh my God, it's poisonous, it's toxic. How can you use so much of it? I mean, they use it for your colonoscopies, okay, and it definitely puts you on outflow once you start taking it. For those people who think polyethylene glycol is so terrible, they should stop eating ice cream, cake mix, Dunkin' Donuts, iced tea, and salad dressing because all of them have polyethylene glycol. So when you read about all these bad side effects of polyethylene glycol, still eating ice cream, eat Dunkin' Donuts, so that they all have polyethylene glycol. So basically, I use it. The dose of polyethylene glycol, I mean, for your colonoscopy, the dose of polyethylene glycol, okay, is basically 0.8 grams per kilo. A capsule of polyethylene glycol has 17 grams. The only issue if you're giving it to small children is you want to make sure they take it with plenty of water because where is the fluid being drawn into the gut? It's coming from the GI tract. So you can give anybody enough polyethylene glycol you're gonna disimpact them. Okay, guaranteed. When you go for your colonoscopy, how many people have had the pleasure of a colonoscopy? Okay, 5 of them. Basically, it's best night's sleep you'll have. Okay, the treatment basically is you take the whole container. You take the whole container and 64 ounces of fluid. So you drink 8 ounces of any fluid with the whole thing poured into it, 1 8-ounce glass every 10 minutes. And in about 2 glasses, you're on outflow, total outflow. Okay, so I mean that's the way to do it. The first colonoscopy, they gave you something called Go Lightly. I love that one. It was a gallon of fluid, tasted terrible, and they told you to drink 10 ounces, 8 ounces every 10 minutes. And I'm a good patient. I got down to the last 4 ounces. I looked at that, it ain't going down. And then they told me I could dissolve it in Snapple. Okay, I could drink 64 ounces of Snapple with no problem. Okay, and now they have this new stuff, 2 glasses of this god awful tasting fluid. Okay, and then you're on outflow. So it's getting easier and easier to do. But you take enough of Miralax, you will be on outflow. That's how you disimpact them. I'll stop here. When I come back, we'll talk about abdominal pain, and then we will talk about endocrinology and last lecture